the ring retractor device will not sit well, resulting only in dilatation and lengthening of the surgical anal canal without prolapse, and the anorexia line will not be exposed adequately. Laparoscopy-assisted colon section biopsy can be performed in any infant or child of any size with rectosigmoid type Hirschsprung disease. If the biopsy site is normal ganglionic, the operating surgeon starts dissection of the colorectal. When dissecting the rectum anteriorly, dissection should only progress to slightly distal to the peritoneal reflection to prevent injury to nerves supplying the bladder and urinary tract. Here you can see the tracker position. When dissecting the rectum posteriorly, dissection should proceed distally, keeping proximal to the external sphincter muscles in order not to injure them. By doing so, blood supply to the rectum is almost completely disrupted, and bleeding is much less, while excising the posterior ganglionic rectal muscle cuff. The anal valves along the dentate line at the bottom of the anal sinuses should be hooked up, otherwise the exposure of the anorexia line will be inadequate. Here you can see the anorexia line clearly. Multiple fine traction sutures are placed proximal to the anorexia line. Both the anorexia line and the anal transitional zone are left intact. The mucosa is incised just proximal to the anorexia line circumferentially using needle-tipped electrocautery. The operating surgeon commences near full thickness rectal dissection transanally, progressing cranially for about 15 mm in the plane of the rectal muscle layer, taking great care not to injure the external anal sphincters. After the 15 mm near full thickness dissection has been completed, a large bore silicone tube is inserted into the rectum as a stent, and the plane of dissection is changed to the submucosal and continued proximally. As mucosectomy progresses further proximally, the rectosigmoid colon, which has already been prepared laparoscopically for pull-through, begins to invaginate into the rectal muscle cuff and reaches the anus. The invaginated muscular wall of the rectum is divided circumferentially, and the proximal rectosigmoid is delivered through the anus externally. The rectal cuff is first divided at the 3 o'clock position. And then divided at 9 o'clock positions into anterior and posterior segments. Next, the anterior rectal cuff is divided in the midline and excised to the point where the laparoscopic dissection was performed. The right anterior rectal cuff is excised. The left anterior rectal cuff is excised. The posterior rectal cuff is divided in the midline, down to where the mucosectomy was commenced. The left posterior rectal cuff is excised. The right posterior rectal cuff is excised. Since the first 15 mm of rectal dissection from the anorexia line is nearly full thickness, the entire posterior iganglionic rectal muscle cuff is now totally removed. Well-vascularized colon is now pulled through. Because of laparoscopic assistance, the distal end of the peripheral colon is well vascularized, which prevents post-operative complications. Sigmoid neocoloplasty, creating an S-curve in the peripheral colon to act as a reservoir to further enhance post-operative bowel function. After the colon is pulled through, a full cycle slice of full thickness colon is taken to confirm normal ganglionosis and absence of nerve bundles circumferentially. Residual mesocolonic fat tissue from distal peripheral colon is removed to ensure effective anal sphincter and pelvic floor muscle contraction. The coloanal anastomosis performed just above the anorexia line using interrupted absorbable sutures with great care not to suture into the anal transition zone, in other words, not below the anorexia line. I think from now, I will show the key points of this video. In the past, we used the dentate line for starting level of the dissection transanally. But if we dissect from to below, after operation, the patient will have incontinence. And if the dissection is far proximal from dentate line, this is dentate line, the patient will have an obstruction post-operatively. So I started to use just proximal from the anorexia line, which called Hermann line. And so all patients have the same. So another key factor is for success of pull-through is in laparoscopic assistance, we can preserve entire marginal artery vein in the distal end of the pull-through colon. But if we use pure transanal, I mean without laparoscopy, often very difficult to preserve the marginal artery and veins entirely. I think it may cause the distal end of the colon ischemia, leading to the post-operative complication. That's why I feel laparoscopic assistance is so important. Also, without laparoscopy, without posterior and lateral dissection of the rectum, proximal to the external anal sphincters, laparoscopically, the posterior aganglionic rectal muscle cuff will retain attachment, preventing natural eversion as far as just proximal to the level of the anorectal line,
transanally. Thus, complete excision of the posterior aganglionic rectal cuff is unlikely, resulting in aganglionic rectal cuff remain posteriorly. I feel just dividing the posterior rectal cuff at 6 o'clock is not enough. I feel we have to remove entire posterior rectal cuff to prevent postoperative enterocolitis and postoperative obstruction. So in my technique, first 1.5 to 2 centimeter is Swenson. Then I switch to the move on to the submucosal dissection, like a Soave. So anterior part is, in my technique, Soave, but after this, as I mentioned in my operative video, I excise entire posterior wall. So posterior part is Swenson procedure. So I call my technique is Swen Soave. And as I mentioned, this is critical for success of the peripheral operations. We have to ask the pathologist whether or not there is absence or presence of hypertrophic nerve bundles circumferentially. If there is a hypertrophic nerve bundles in the, for example, 3 o'clock, 6 o'clock, this indicates this colon is not normal. This colon is transitional segment. So we have to ask the pathologist presence of ganglion cells and absence of hypertrophic nerve bundles circumferentially. This is one of the critical points for success of peripheral procedure. And I prefer create S-curve. I feel this S-curve act as a reservoir post-operatively. In my experience, if this colon is straight, I think post-operative function to become normal takes a longer time. And also, rectum doesn't have a adipose tissue around the, surrounded with the external sphincter. So I try to remove mesocolonic adipose tissue. Thank you. Then I want to show my outcome. Can you see my slide now?
Yes.
So outcome, we reviewed 80 consecutive rectal sigmoid hysterectomy patients we treated using this technique between 2007 to 2019 at our affiliated institute. In this cohort, the median age at peripheral was 9.5, mean follow-up 7.5 years. Surgery proceeded uneventfully in all cases. Overall incidence was post-operative complication. Overall incidence was 7.5%. 6 other complications, as you can see. 5 cases, colloidal anastomosis, stenosis requiring buginage. 3, protrusion of colon from anus, probably due to inadequate colloidal anastomosis requiring excision of the protruding colon. 1 case, visible anal mucosa from 2 to 5 o'clock requiring excision. 1 case. 1 case had transitional peripheral colon who had a grade 3 enterocolitis. The 5 treated cases currently have normal bowel function. The overall incidence of postoperative enterocolitis was only 6.3%, And grade 3, as I mentioned, only one case who had a truncal segment peripheral colon. Post-operatively, we review the histology. There was hypertrophic nerve bundles circumferentially. Even there is the ganglion cells circumferentially. Grade 2, due to cholanal stenosis. The other one is uncomplicated cases, but the patient had grade 2 enterocolitis. One case had grade 1 enterocolitis, who had a anal protrusion case post-operatively. So post-operative bowel function, 11 cases with chromosomal anomalies or intellectual disabilities were excluded. 69 cases were evaluated using a continence evaluation score we developed and reported in the PSI and JPS. So 91.3% has normal bowel function. Problematic cases had 6 cases. Staining, 3 cases. Unexpected passage of a motion, 1 case. Requirement of assisted defecation, 2 cases. Here you can see the conclusion. Thank you very much. This is the end of my presentation, Thomas.
Thomas, you can unmute yourself.
Thomas.
Now I have unmuted myself. The system didn't allow me to unmute myself. Thank you very much, Yama, for the very nice presentation.
Thank you.
I have one question. You described that you start with a full thickness dissection above the anorectal line, and then you go into the submucosal plane. Why do you do it like that? Why don't you continue doing a full Svensson procedure?
You know, when I read the Svensson procedure, even in his experience, in his hand, I think not many, but only a few, but few cases had the urinary problem post-operatively. I do not want to touch posterior wall of the bladder. That's why I want to keep the swabe procedure in the anterior side, not full thickness. The reason why I do first 1 to 2 centimeter full thickness is if I studied this submucosa plane, I think, you know, my experience, very difficult to, you know, to do the transanal dissection. I think first stitch should be the suture to the muscle layer. Then follow, after that, easy to do transanal submucosal dissection.
Prem has a question.
Yeah, same question as Thomas, because before I started doing the transanal pull through all my life, I did Svensson procedure because I was trained by Barry O'Donnell, who was trained by Svensson. But if you stay close to the wall of the rectum, you do not get any urinary problems, you know. So what I'm saying is, but Thomas said, if you start at Svensson, you can continue so long you stay close to the rectal wall, you won't have problems.
Thank you very much for your advice. I may try next time, both from the laparoscopically from the top and from the bottom, Svensson procedure.
Too much.
Mr. Gupta.
Thank you, Yama, for this new innovative procedure. I think a long time back, Professor Miano also told me in 2002, it was, is that about this combination of the procedures he was planning. And the objection is quite obvious that the very basic problem with Svensson is not to have dissection outside the bowel. And yesterday also we heard in a couple of papers that there were urinary problems apart from the other chances of complications with Svensson. So that is the reasons Ball-Scott principle or the Suave's original is always preferred not to touch anything outside in the pelvis. When you are doing Suave already, so why not to bring it down? And I tell you, when we do transanal and start dissection, especially in the newborns or small infants, the bowel wall is so thin at the lowermost end, just above the dentate line, about a centimeter or two, that it tends to become the full thickness inadvertently. The mucosa and the muscle wall are almost of the same thickness. So that is a real problem. Hence, it may help for those who try to separate the mucosa from the muscle coat, but actually the muscle coat also gets involved into it. Hence, I think one has to think twice before resorting to start with Swenson and then switching over to the Suave. That is the first thing. Second, you commented on the vascular supply to the bowel. Whether you do manually, whether you do laparoscopically, the continuation of the inferior mesenteric artery should be preserved as a principle of Suave surgery to maintain the high vascularity of the cuff. The cuff will remain viable even if you divide this vessel. Doesn't happen. But in cases where there are a lot of polyps with lot of vascular supply and lot of bleeding with the base of each polyp, then intentionally this vessel has to be divided so that there is less bleeding during surgery while performing Suave principle for colectomy. So these were my two comments. Thank you very much for your video.
Thanks for your nice comment.
Thank you very much. I think most of the comments or questions in the chat are related to how to deal with the cuff and whether the Swenson should be a full Swenson should be a good alternative. There is one question about enterocolitis, and I just wonder, you report a very low incident of postoperative enterocolitis compared to many other series. It's quite often reported that 20 or 30% of patients have enterocolitis. Do you think, is that due to the technique you use, or is there another explanation for the low incidence of enterocolitis?
Yeah, recently we submit the paper to the IPEC because in our institute and affiliated hospital, the incidence of enterocolitis is, I think, very low, and maybe low in Japan. I don't know why, but especially in my institute is very low. I think post-operative enterocolitis is related to the post-operative obstruction. I think if the dissection is too high, I think the surgeon may remain the aganglionic segment circumferentially above the anorexia line. So the patient tends to have an obstruction post-operatively. In my opinion, the enterocolitis is strongly related to the technique.
And Yama, what about the incidence of enterocolitis before surgery? Is that incidence also lower in Japan, or is it?
No, in the IPEC abstract, just 2 or 3 days ago, I submitted. I think the incidence was, I think 17%, something like that. But still low, but higher than preoperative enterocolitis. But I rarely see, even preoperatively, we rarely see the grade 3 enterocolitis in Japan. I think when I talk to the other pediatric surgeons in Japan, I think a Japanese pediatric surgeon told me they also, their experience also similar to me, I think.
So, thank you very much, Yama. I think we are moving on to the next presentation, but thank you, very nice presentation. And before moving on, Professor Gupta has an announcement.
No, it was Professor Thomas and Professor Yama, just to appreciate the guest lecturer of Professor Yama, who has immense experience and always with innovative ideas. He comes to the PCC meetings. I appreciate very much Professor Yama. You are truly leading the legacy of Professor Suruga, Professor Miyano in the famous Juntendo University. Keep it up. All the best.
Thank you very much.
So thank you.
And
So
Dr. Pena has raised his hand if you'd like to ask him.
I have a question, Yama. The case that you presented looks like a typical Hirschsprung case of rectosigmoid aganglionosis, but I'm sure you have cases of extended aganglionosis, not total colonic aganglionosis, but aganglionosis extending to the splenic flexure and transverse colon. And with your technique, everybody will believe that you continue doing submucosal dissection, suave dissection, all the way up to the splenic flexure and transverse colon. Is that what you do? And when you start the operation, do you already have a diagnosis of the extension of the aganglionosis? You have any studies done pre-operative that give you an idea how extensive is the aganglionosis? And how do you diagnose that? Because you show us that you take the donut to determine that there is no transition zone. But what about before you start the operation, do you have an idea how extensive, how long is the aganglionosis? And how do you handle the cases in which the aganglionosis extends to the transverse colon?
Thank you very much for your comment, Alberto. This paper, my outcome only showing the rectal or rectosigmoid type Hirschsprung disease. The outcome for longer type of the Hirschsprung disease, even using my technique, the outcome is not good as much as the rectal and the rectosigmoid type Hirschsprung disease. In my technique, in other words, in my technique, the longer segment, total colonic Hirschsprung disease, I used this technique, but the outcome is not good as much the case I showed today. And regarding the second question, yes, several times I have a trouble when I take a donut's biopsy. 1/3 is okay, but 2/3 sometimes hypoganglionic. So in that case, I put the peripheral column back to the abdomen, and then I have to do full thickness biopsy laparoscopically, or I have to make small incision, or I have to take biopsy through the umbilicus. So sometimes, not many, I have to take biopsy transverse colon and ascending colon. So it happens, but initially I always do the technique which I showed. But when I take a donut's biopsy, if the circumferential biopsy doesn't show normal and circumferentially, I put the column back to the abdomen, I will take biopsy to get the circumferential normal biopsy parts. So in that case, sometimes I have to pull through the transverse colon, I have to pull through ascending colon. In that case, post-operative outcome, bowel function is not good as much as rectal and rectosigmoid type Hirschsprung disease.
Prem?
I think Alberto has raised a very good point about the extent of the aganglionosis and going through the transanal pull-through, because transanal pull-through is dependent so much on, decision is dependent on the properly performed contrast enema. I certainly have been fooled 3 times when I started the procedure. I'm sure many of you probably had the same experience. When I started the procedure from transanal, because we have been shown by radiologists that this is a rectosigmoid disease, and in 3 instances, I ended up having a total colonic aganglionosis. And before I started the procedure in the newborn period, I had to do the in so I think that it would be great because the decision is very contrast animal.
Alberto, my reply was understandable. Did I reply to your question?
Yes, but my question is, before you start the operation, do you have a precise diagnosis of the extension of the aganglionosis?
No, I don't decide.
That's number one. Number two, do you continue the submucosal dissection all the way up to the transverse colon if the aganglionosis is that high? Do you continue submucosal? Because that's what in your presentation you say that you start full thickness and then you become submucosal. How far do you go submucosal? All the way up to the transverse colon, or what? How do you do that?
Yeah, only the submucosal dissection is up to the colon started to prolapse through the anus, that level, not to the splenic flexure, not to the transverse colon. When the started to the proximal colon, prolapse through the anus, I stopped the submucosal dissection.
Good, very good. I think now we move on to the next presentation.
Thomas, may I ask a question?
Okay.
Yama, I was surprised that you left quite a lot of sigmoid colon intentionally to have not a straight colon going down to the anus, but to have a kind of a flexure. So, but I'm surprised most of the normal Hirschsprung disease extent of the normal goes up to the sigmoid. How can you leave such a lot of sigmoid colon postoperatively?
I think the rectal and the rectal sigmoid type Hirschsprung disease, I think 2/3 of the sigmoid can, I think we can preserve. That's my experience. But if the aganglion segment is up to proximal to the sigmoid colon, of course we cannot make the S curve. But sometimes in rectal sigmoid type, I cannot make the S curve, but the rectal type or lower 1/3 of the rectal sigmoid type, I try to create S curve for dissecting the descending colon up to the splenic flexure.
Good.
Okay.
Thank you. I think now time is flying, so we move on to the next presentation, which is also from Professor Yamataka's group. And it's a presentation from Dr. Fujiwara. And the title is Lessons Learned from Lower Urinary Tract Complications of Anorectoplasty for Imperforate Anus. And it's a comparison between laparoscopy-assisted technique and posterior surgical approach. Please.
Nothing to disclose. We present long-term follow-up of sequelae of lower urinary tract complications in male imperforate anus with rectovascular or rectourethral fissure. The aim of this study was to report the sequelae of lower urinary tract complications in male imperforate anus with rectourethral or rectovascular fissure using laparoscopy-assisted anorexia or PCC, and present preventive strategies. There were 153 patients who treated at Juntendo and Helsinki. Of these, 56 were treated by lab and 97 by PCC. Lower urinary tract complications were compared. Lower urinary tract complications such as posterior urethral diverticulum, intraoperative lower urinary tract injuries, post-operative dysuria, and fissure recurrence were assessed. Results. Types of imperforate anus are shown. In lab, vascular in 6, prostatic in 26, and bulbar in 24. In PSAP, vascular in 6, prostatic in 51, and bulbar in 40. Lower urinary tract complications were 5 posterior urethral diverticum and 1 dysuria in lab, and 5 lower urinary tract injuries, 1 dysuria, and 1 fistula recurrence in PSAP. Rate was 10.7% in lab and 7.2% in PSAP. It was not significantly different. During the study period, technical strategies have been devised to help prevent lower urinary tract complications. For lab, incomplete excision of a urethral fissure was considered to be a problem. So, a novel technique for the intraoperative measurement of the remaining length of the urethral fissure using fine catheter and the endoscopic control was devised. For PSAP, a distal calcium is mandatory for definitive preoperative surgical planning. To dissect safely, surgeons must be familiar with the level of the distal rectal pouch in order to plan the best angle of approach for dissection. I will show you that example. Case 1, bowel fissure and the distal pouch is below the coccyx. Surgeons will be able to identify the distal pouch by dissecting directly downward. So, serious injury to lower urinary tract is rare. Case 2, bulbar fissure, or case 3, prostate fissure. The distal pouch is far above the coccyx. If the approach for dissection is directly downwards, the surgeon may become disoriented and injure the lower urinary tract before identifying the distal pouch. So, serious injury to lower urinary tract is likely. For preventing lower urinary tract injuries, surgeons should dissect diagonally upwards to the coccyx. Then follow the coccyx inferiorly to find the distal pouch lying almost parallel to the sacrum. Lower urinary tract injury is unlikely. After technical refinement, lower urinary tract complications have been zero. Next, we show the treatment of complications and outcome. The details of 5 posterior urethral diversions in lab are shown. 3 cases are observation because
Fujiwa, you can now unmute yourself. Unmute yourself.
Can you hear me?
Yeah.
Thank you. Five lower urinary tract injuries in PSAP are shown. Site of injuries were prostate in 2, seminal vesicle in 2, and prostatic utricle in 1. All cases were repaired. And remarkable recovery in 4 and chronic epididymitis in 1. In conclusions, lower urinary tract complications differs because of technical issues, but are now uncommon after devising strategies to improve dissection accuracy. Thank you.
So thank you very much for your presentation. There are a couple of questions in the chat. There is one comment from Professor Peña and Dr. Bischoff.
Well, it just called our attention that in 6 patients with rectal bladder neck fistula, they were operated through PSARP. We commonly say that if you have a rectal bladder neck fistula, the separation of the rectum from the urinary tract should happen through the abdomen. So it called our attention. And when the distal colostogram that was used to show a rectal prostatic fistula, in my opinion, this is a rectal bladder neck fistula. So that's my only comments, but I'm happy the authors have found strategies to avoid injury.
And also, the author presented a complication called orchioepididymitis and says that he corrected the orchioepididymitis. Orchioepididymitis is not a surgical complication. It should not be a. Orchioepididymitis occurs for other reasons. Sometimes it's an ectopic connection between the vas deferens and the urinary tract. It's nothing that we can provoke by in the operation. Or how do they provoke orchioepididymitis, and how did they solve that? I didn't understand that.
You want to respond, Dr. Fujimura?
I think I have to reply. Regarding the PSARP procedure, after we revise the technique, and as I mentioned, the complication is decreasing. And but before that, we always to see make the otomy in the distal colon and the fistula, then to see the lumen first. Then we started dissect the anterior wall of the fistula. I think that's the key to prevent the serious complication. Injury to the urethra and the prostate, in my experience. First, make the vertical incision in the fistula, then to see the lumen under direct vision. The anterior wall of the fistula. Then we started dissect between the fistula and the urethra, decreasing the complication of the fistula.
I have an additional question. You had not that many, but which approach did you use to repair or excise the posterior urethral diverticulum?
So one case had dysuria. So I have to manage. That was, as I mentioned before, during the residual length of the fistula during the operations. And in that case, the patient had dysuria, I have to make the fan and steel incision, then open surgery, and then I excise the entire residual fistula. That was a prostatic case. Bulbar fistula, luckily so far the patient is asymptomatic, so we are doing observation. But in future, we may have to excise the residual residual enlargement of the remaining fistula.
But do you do it with laparoscopic assisted or with?
The first case, I do open surgery, but now I have a confidence to measure the length of the residual fistula. So I think we try to laparoscopic excision, like excising a male vagina.
Good, thank you. Are there more questions? Then I think we move on to the next presentation. Thank you very much, Dr. Fujimura. Thank you. And the next paper is also from Japan. It's presented by Dr. Onishi, and the title is Transperineal Transection of the rectobulbar urethral fistula using a 5mm stapler, which is described as a novel and secure technique. Please, Dr. Onishi.
Good evening from Japan. Thank you for this opportunity. I will start my video. Sorry. I will start again.
Meanwhile, Yama, there's a question from Michael. Do you see all your patients with prostatic fistula? Do you see the coccyx in all your patients?
So could you say again? Sorry, I didn't get.
There's a question from Michael Holworth. Did you see in all your patients with prostatic fistula the coccyx? The lower part of sacrum?
Yes.
Was it
yes.
present? Was it present in
some cases it doesn't have, had a tethered cord, and in some cases, few cases as sacral anomalies.
Thank you.
Can I start my video again?
Sure, sure. Onish, raise the volume of your video. We cannot hear the volume.
Excuse me?
We can hear you, but not the volume of the video. So just increase the volume of the video.
Okay.
Or if you want, you can read it out.
Can you hear the video?
We cannot hear the video. We can hear you. So either you can increase the volume of the video, or you can start speaking yourself.
Okay.
Fistula has not become a standard practice.
Yes, yes. Now we
because
can hear. Thank you.
Can I start
the
here?
nail anus using 5 mm stapler or rectovulvar urethral fistula treatment in LAARP. Nearly 20 years have passed since laparoscopically assisted anorexia LAARP was first reported. LAARP is now widely applied. However, LAARP for rectovulvar urethral fistula has not become a standard practice because of the risk of the urethral injury and incomplete fistula removal. Recently, 5 mm stapler was introduced in pediatric end surgery, including LAARP. From laparoscopic view, the rectovulvar urethral fistula is located at the most deep pelvic space and technically difficult for secure transaction from abdominal approach due to the small pelvic space and distance from the abdominal trocar. By changing the concept of the approach direction, we thought of the transaction from perineal region through nail anus using 5 mm stapler, because the rectovulvar urethral fistula is close from the perineal region. A 3 kg term male neonate was born with an anorexia. In the neonatal period, left transverse colostomy was performed at the left upper quadrant. LAARP was planned to be performed after his body weight reached over 6 kg. Before anorexia, a distal colostogram was performed, and the patient was diagnosed with rectovulvar urethral fistula. Under general anesthesia, the patient was placed in the rhizotomy position. A 5 mm port was inserted at the umbilicus by the open Hudson method. Then 3 additional trocars were inserted. Before the laparoscopic procedure, the rectovulvar fistula orifice was confirmed using 2.8 mm flexible cystoscope. The bladder was suspended in order to obtain a sufficient operative view. The perineal reflection and rectum was carefully dissected using 3.5 mm bipolar scissors, keeping the dissection line between the prehypogastric nerve fascia and the fascia propria of the rectum is important for preserving the pelvic nerve. Before transection of the fistula, the center of the muscle complex was confirmed from outside using an electrical nerve stimulator. The muscle complex, including the puborectal sling, was then laparoscopically confirmed using 3.5 mm bipolar forceps. A pen was inserted to keep the center of the muscle complex away from the perineal skin incision, and a 5 mm trocar was replaced through the center of the muscle complex. The 5 mm stapler was inserted through the perineal trocar, and the rectobulbar urethral fistula was held by 5 mm stapler. The operator confirmed the adequate closure of the fistula using the dual view of the both laparoscopic view and the urethral view under flexible cystoscope observation. The rectobulbar urethral fistula was transperineally stapled and transected using 5 mm stapler through the trocar placed at the neo-anus. The stapled rectum was pulled through and the stump was sutured to the perineal skin.
We've lost your audio.
Here it continues.
Transperineal approach using a 5 mm stapler was effective and useful for the secure treatment of the fistula in the case laparoscopic assisted anorexia for a patient with a rectobulbar urethral fistula. The concept is sometimes useful and effective for surgical procedure in technically difficult situations.
Thank you. This is over.
Thank you very much for a nice video. There are some questions. There is one question. Will it be a better idea to manage residual? Oh, that was an old one. There is a comment regarding the metal staples in contact with the urethra. Is there a risk for migration?
Oh, we didn't have any complication after this operation, so we think it is not problem.
And the risk of stone formation with the metal clips in the urethra?
Sorry, risk for
stone formation, calculus.
Oh no, there are no stone formation. This operation we are following him after operation 1 year. He's now, I think, 1.5 years old, but he has no stone formation or complication, urethral complication.
Thank you.
So, can
Question.
I?
Professor Peña?
Yeah. If you already fix the fistula, the vulvar fistula from below, and then just and the rectum is very close to the skin, by a very short dissection, you will finish the operation without invading the abdomen. So this is a laparoscopic maximally invasive operation. And then you did not mention the incidence of prolapse. And actually your work is very interesting because it shows that you are a great ingenuity, creativity in a persistent to use all the laparoscopic equipment that you have, and the refusal to make it simple operating from below. When a rectourethral vulvar fistula, once you separate the rectum from the urethra, you just have to dissect a little bit and the rectum very easily reaches the perineum. but we don't have to dissect the entire rectum all the way to the peritoneum. When laparoscopically, by definition, you dissect everything, and the consequences are very well known, one of which is the rectal prolapse.
Thank you.
There is another question in the chat. How long is the follow-up of these patients?
Oh, we follow up until they will not come to hospital. We will follow up to until they become adult. Yeah. So we have over adult patient in our outpatient.
So thank you very much. If there are no more questions, I think we move on to the next paper.
Thank you.
Thank you. And the next paper is presented by Dr. Verli, and the title is Comparison of the Outcome of Two Different Surgical Techniques in Patients with Megarictus Sigmoid Due to Idiopathic Constipation. Please, Dr. Verli.
Good morning. Hello, everyone. Good morning or good afternoon or good evening, wherever you are on this beautiful earth. So, dear Chairman, thank you very much. Dear colleagues, also thank you for this opportunity to present our work. Up to this date, there is no gold standard for the surgical treatment of severe idiopathic constipation with megarictus sigmoid. So our goal is to improve surgical care in this patient. So the purpose of this study was to compare the outcome of patients suffering from severe idiopathic constipation with megarictus sigmoid who have been subjected to do two different operative techniques. We performed a retrospective, descriptive, and observational study, which was approved by our IRB. We included patients that have been operated on from January 2014 to April 2019. Statistical analysis was performed using SPSS version 25.0 with the Wilcoxon test. Group A included patients who underwent a transabdominal sigmoidectomy, where the resection line started at the peritoneal reflection. Group B included patients who underwent a transanal approach, and the resection line started 5 centimeters cranial to the dented line. Post-operatively, these patients have been evaluated for daily voluntary bowel movements as a sign for fecal control and the amount of reduction of laxative dosage. Again, Group A included patients who underwent an abdominal sigmoidectomy, and Group B included patients who underwent a transanal rectosigmoidectomy. The number of patients in each group were 17 patients. The range of age in Group A was from 3 years to up to 18 years, with a median of 9 years. In Group B, the age range was from 2 to 19 years, and the median was 8 years. Mean follow-up time was 50 months in Group A, and in Group B, 22 months. Voluntary bowel movements in Group A achieved 9 patients. 8 patients out of these 17 did not have daily bowel movements and therefore have been treated with enemas. In Group B, daily voluntary bowel movements as a sign for fecal control have achieved 16 patients. Laxative reduction was possible and feasible in 9 patients in Group A, and in Group B in 13 patients. The laxative reduction, so the amount of laxative reduction in these 13 patients from compared to the post-operative amount of laxative used to provoke a daily bowel movement was significant, meaning that the amount laxative used pre-operatively ranged from 75 milligrams to over 500 milligrams, which was a mean of 160 milligrams of senna, compared to post-operatively in these 13 patients, then using 7 up to 75 milligrams senna daily with a mean of 30 milligrams of senna. Recurrent fecal impaction occurred in group A in 12 patients, in group B in 1 patient. So to conclude, both surgical techniques are improving to problematic megarectosigmoid due to severe chronic constipation in these patients. However, the transanal proximal rectosigmoidectomy resulted in a higher rate of bowel control, lower rate of fecal impaction, and in a significant reduction of the laxative dosage. Thank you.
Thank you very much for a clear and nice presentation. I have one question. In the, particularly in the group B, the transanal group, did any of the patients experience incontinence?
No, none. One patient is still on enemas because he's not, how should I say, he's not tolerating the sinusoids. So we are currently having him on enemas. Also, just a remark, on these 13 patients that have been successfully weaned from the laxatives, we haven't included 4 patients. So out of these 17, 4 patients, we couldn't really compare the laxative dosage used preoperatively versus postoperatively, because 2 of them have been preoperatively on enemas, and the other 2, one was on Miralax and one was on Bisocodyl.
Thank you. There is one question in the chat, and it's, isn't it difficult with a transanal dissection in cases with very dilated rectum?
So the dilation is not really the issue. The issue is that there is a fibrosis. In chronic, long-standing, severe constipation, the tissue gets very fibrotic, and that makes the dissection quite hard and difficult to find the right plane, because it's a full thickness dissection.
Prem has a question.
Can you tell us more about this 2-year-old patient in group 2 who needed this procedure, because redundant dilated colon in an idiopathic constipation 2 years is very rare. I mean, can you expand on this patient a bit more, 2 years old?
Okay, first of all, we excluded that she's not suffering of Hirschsprung disease. So we took biopsies that came back with ganglion cells. This patient, then we started on a very strict bowel regimen, but she could not pass daily bowel movements. And also, the patient did not tolerate the enemas. So the patient and...
My question to you is, I mean, megarectosigmoid in a 2-year-old is very rare. Idiopathic constipation. So.
Yes, it's very rare. And I want to note that these are all very selected cases. They all have shown a megarectosigmoid. Unfortunately, I don't have the X-ray here or the contrast study of this young little girl, but she was having a very impressive megarectosigmoid, and she did not do well with the laxative trial and with the bowel management. Therefore, we then proceeded to do a surgical approach. Yes.
Well, I would like to say a comment. First, I agree with Prem completely. To have patients at the age of 2 years and 3 years not to be able to perform a conservative management of this chronic constipation, it's really surprising for me. Essentially is that in this conservative management, you have to evacuate the whole feces into the colon, and then you can start with therapy, whatever you are using. And you have to control it very carefully. The other point which I would like to mention is, you are coming from Lucerne in Switzerland. It's not so far away from Bremen. And Rehbein, and I was trained by Rehbein, we had a number of, at that time, today it's very rare to see them. We had a number of patients at that time with a huge mega colon, not Hirschsprung disease. And his procedure, and I did it also in my clinic later on, was to remove all the dilated colon and leave the rectum, but excise a large triangle of the rectum on the dorsal side, thereby making smaller the circumference of the rectum, and then to adjust it to the normal colon circumference. That was a technique by Reben, and it was very successful at that time. But today we don't see that nearly, very extremely rarely. I don't know how it is in Switzerland.
It's rare too, that's true.
Thank you very much.
Dr. Wester, may I a short question, please?
Yes.
For Evgeny Pimenov from Moscow, Russia. You have 12 patients in group A with recurrent bowel infection and only 1 patient in group B after transanal pull-through. What do you think about it? What is the reason, for your opinion?
So the reason that in group A, these patients suffered of recurrent fecal impaction was, so a large of these, or a big number of these 12 patients have been then on laxatives, and they couldn't really evacuate all the stool. Our hypothesis is that the remaining rectal pouch with its dysmotility is not really contracting, and so the evacuated or the evacuation of feces is not sufficient. Therefore, they do suffer of recurrent fecal impaction, which did not happen on the patients that have been on enemas in this patient group.
Thank you very much. There are another few questions in the chat, but I mean, usually being the chairman, you say that, well, you could discuss this over the next coffee break, but that's a bit difficult. So, but you can have a look at the chat and see if there are some more comments you want to respond to. So then
I'm happy to answer questions. Thank you.
So then I think we move on to the next paper. So thank you very much. And the next presentation is again from Professor Yamataka's group, and it's Dr. Miyake who is presenting. And the title is Kidney Structure and Function in Dilating Vesicourethral Reflux Patients with Anorectal Malformations. So please, Dr. Miyake.
Thank you very much for Chairman. Nothing to disclose. First, VUL is a common anomaly in patients with anorectal malformations, and the presence of dilating VUL increases the risk for the UTI, which may lead to scarring and subsequent renal dysfunction. Recently, bladder and bowel dysfunction has also been reported as a risk factor for UTI and renal scarring in VUL patients. So we thought BBD is possibly more likely to complicate anorectal malformations because of the anatomical anomalies already present in the anorectum. Therefore, the aims of this study were to investigate the impact of ARM on renal function and BBD in children with dilating VUL, and the renal function behavior of dilating VUL with ARM. We reviewed 121 dilating VUL cases treated between 2000 and 2014 retrospectively. 18 cases were excluded as being secondary causes of VUL. Subjects were divided into 2 groups according to the presence of ARM. ARM plus 12 cases, ARM minus 91 cases. These are evaluation parameters: patient demographics, VUR grade, incidence of UTI, prophylactic antibiotics, presence of BBD, renal dysfunction scores, and renal function behavior. BBD was defined by the American Urological Association. We used simple renal dysfunction scores determined from DMSA scintigraphy. Score 0 is the best, score 2 is worst. Examples: score 0, non-renal parenchymal lesion. Score 1 lesion or split renal function greater than 40%. Score 2M, multiple lesions or split renal function less than or equal to 40%. Score 2D, diffuse lesions or split renal function less than or equal to 40%. Results: gender, mean incidence of UTI, prophylactic antibiotics, bilateral VUL, and mean duration of follow-up were similar in both groups, but the presence of BBD were significantly higher in ARM+. The severity of VUL were similar in both groups. Then this table shows renal dysfunction scores in both groups. DMSA scans indicated that severe renal cortical lesions were identified significantly more often in ARM+ than in ARM-. In ARM+ group, the grades of VUL were not significantly different with respect to RDS. On the other hand, in ARM-, the grade of VUL were significantly lower with low RDS, and the grade of VUL were significantly higher with high RDS. Furthermore, as you can see, there was no tendency for mean uptake on DMSA scintigraphy to deteriorate after definitive corrective surgery in ARM+. The renal function did not appear to change over time in ARM+. Our results indicated the following. First, ARM+ had significantly higher RDS than ARM-, despite both groups having similar grade of VUL and incidence of UTI. And the incidence of BBD in ARM was significantly higher than in ARM-, but no progression in renal cortical lesions was observed in ARM+. So, in patients with anorectal malformations, BBD did not appear to contribute to progressive renal dysfunction as is commonly believed. Thank you for your attention.
Thank you very much for a nice presentation. There is one in the chat asking, it's from Dr. Moreno, why did you exclude 2 patients with cloaca?
Cloaca is, the cloaca patient all colorectal patients have lower urinary tract dysfunction, and we think the VO in colorectal the cause of secondary VO, so we excluded the 2 patients.
Prem, you had a question.
Unmute yourself, Prem.
I was interested in relation to gender and BVD in your patients. We recently published a paper in Pediatrics, over 800 patients who have been successfully treated with endoscopic treatment with VUR. And we looked at the patients who had, this was a long-term follow-up, who had febrile urinary tract infections after successful treatment. There were 43 patients who had 2 or more urinary tract infections, febrile, and 26 of them had BVD as the cause. But interesting finding were all the 26 were females. We did not have one single male with BVD. But in your study, I know we're not talking about ARM, but it was VUR, but we did not have any patients, whereas your males and females were the same as BVD. Thank you.
Thank you very much.
Questions? I don't think there is anything else.
There's one more question. BBD will be almost universal for ARM patients. What is your view on that? Is bowel bladder disease universal for all anorectal malformation patients?
Prem, is this correct?
Not correct.
Thank you. This is my answer.
Good. So then I think now Professor Yamataka will introduce the next speaker. So thank you. Thank you very much.
Very much.
So next paper from India by Dr. Mamuta. Please.
Good evening all. Is my screen visible?
Yes, go ahead, Mamta. You're visible.
I'll be presenting lower urinary tract dysfunction in patients with anorectal malformations. And as we all know that urological anomalies are the most common causes of morbidity in patients with anorectal malformation, especially the older children. And many anomalies have less number of functioning renal units or have conditions with risk of continuous damage to renal functions, ending into end-stage renal disease. So lower urinary tract dysfunction, if present in such cases, might have detrimental effect on already existing or already compromised renal functions. So we reviewed the literature about lower urinary tract dysfunction in patients with anorectal malformation to see what is well known and what is less well known. So we could see that neurogenic LUTDs are very well studied, but as regarding to VUR, there is still persisting dilemma about whether it is primary or a secondary VUR, secondary to lower urinary tract dysfunction. And there are no recommendations formed for management of vesico-ureteric reflux and or UTI in these patients. The functional LUTDs are less well studied. This is a study which is have a 15-year follow-up and is a longitudinal study done on well-trained, bowel-trained and bladder-trained patients. And this study found 14% incidence of lower urinary tract dysfunctions in their patients. And they could see that there were breakthrough infection along with vesico-ureteric reflux, which were more in these patients. And there were UTI even in absence of vesico-ureteric reflux and spinal anomalies. Other studies done on vesico-ureteric reflux, on single functioning kidney in association with anorectal malformation, or in epididymo orchitis they again showed that there were incidences of urinary tract infection even in absence of spinal malformation and VUR. So the study here was planned to find whether apart from anatomical genitourinary anomalies and spinal malformation, are there other factors too existing with ARM which can affect the functioning of lower urinary tract. So the duration of my study was 2 years, and it included all toilet trained babies who consented for regular follow-up and participation in study. And the patients with syndromic association and global developmental delay were excluded. The data analyzed was mainly focused on urological symptoms and the urological workup. We could not do urodynamic studies in this patient, although we know that this is the gold standard. So urinary symptoms were present in quite a significant number of patients. The most common was dribbling, and the urine routine analysis also showed asymptomatic bacteriuria in a significant number of cases, and there was patients with symptomatic urinary tract infection and breakthrough urinary tract infection. Important point to be noted here is the breakthrough urinary tract infection were subsided in patients with CIC and augmentation cystoplasties. The ultrasound findings were also indirectly showing the evidences of presence of lower urinary tract dysfunction by showing the bladder wall thickening and post-void residual volume. And VCUG findings were also suggestive of bladder changes in form of bladder wall irregularity and post-void and bladder neck hypertrophy. And this in many cases was not associated with vesico-ureteric reflux. And there were urethral anomalies too in some patients. And then we correlated these findings with the presence of spinal anomalies. So we could see that in 11 of our 60 cases, there were non-neurogenic neurogenic bladder, although they are still awaiting urodynamic study. So in 7 patients with renal failure in our study group, we could see spinal anomalies only in 3 patients. The serum creatinine values were stabilized in patients on CIC, and those underwent augmentation cystoplasty. So to conclude, lower urinary tract dysfunction can be seen even in absence of spinal malformation in patients with anorectal malformation, and the severity of lower urinary tract dysfunction changes with time. And so we should include regular urological follow-up in patients with anorectal malformation, and the patients with associated genitourinary malformation should be more closely followed. Thank you.
Thank you very much. Any comments or questions?
There is none in the chat box.
Okay, if not, we are running thank you very much. So moving on to the next presentation. The next presentation is number 34, presented by Dr. Sharma. Please.
Good evening, everyone. Myself, Dr. Shyamendra, going to present. Yeah. Good evening, everyone. Is my slides are visible or not, sir?
Yes, they are visible.
So, myself, Dr. Shyamendra Pratap Sharma, MCH from Department of Pediatric Surgery, IMS BHU, going to present our experience of 6 cases of common cloaca during 10-year period with total urogenital mobilization. Incidence of persistent cloaca is 1 on 250,000 population. Surgery is the mainstay of the repair of cloacal anomaly. Creating a separate channel and opening of intestinal gynecological and urological structure is the aim. And to enhance the function of each system, more importantly, the catheterizable urethra. Aim of our study is to present our experience in management of short common confluence less than 3 centimeter common cloaca over last 5 years and presented here with the as a case series. Material and method, that it is retrospective analysis of hospital data, image copies, follow-up record by single surgical clinical unit from September 2010 to August 2020. The common cloaca cases are the common channel less than 3 centimeter. High common channel cases were excluded, maintaining a single management plan being followed. The total number of cases are 6 patients. Case details. Proximal descending colostomy was performed with decompression of urogenital sinus in 2 out of 6 cases. Definitive procedure was done at 3 to 6 months of the age, considering financial and social constraints of the patient. The mandatory pan endoscopy following MRI pelvis was ensured in all of our cases. The total urogenital mobilization with posterior sagittal approach was performed, and all cases were followed up ranging from 1 year to 5 years. Data were of single surgical unit to present the uniformity of the single surgical approach and the surgical step. This is the image of the one patient, distal chromogram and MRI of pelvis, showing distal vagina, anal canal, and the urethral opening into the common channel less than, it is 1.5 centimeter. This is the pan endoscopic image of the patient, showing that short common channel is 2 centimeter. All 3 urethral, all 3 openings are visualized, and bladder neck are well developed, and single vagina with no septation and single cervix seen, and fecal is seen in the rectum. And standard total urogenital mobilization with posterior sagittal anorecto-ureterovaginoplasty is done in all cases. Our results, thus, out of 6 cases, 1 case has patent vitellospinal duct as associated anomaly, 1 has unilateral absent kidney, another is bilateral hydroureteronephrosis, 1 has no abnormality, and 2 cases has 1 has tethered cord and 1 has sacral agencies. And these patients develop incontinence. So 1 is managed with the clean intermediate catheterization and laxative. Now discussion, as we all know the classification of common cloaca. Our cases fall in the low cloacal malformation, short urogenital sinus less than 3 centimeter, or confluence below PC line. So now discussion, the cloaca is divided into simple and complex varieties depending upon the length of the common channel. So total urogenital mobilization or urogenital suppletion could be planned. On-table endoscopy and 3-dimensional genetogram are useful in modality to assess the patient's anatomy. And laparoscopy or laparotomy warranted is to determine the location of the rectum. The management of the anorectal component of the cloaca is relatively easier based on its nice submucosal vascularity. In a case of higher position of rectum as compared to the confluence, the mobilization is very difficult. Vaginal walls has precocious submucosal blood supply and also papery thin shared with urethra. So to urogenital mobilization is labile for tissue ischemia, especially is performed along with abdominoperineal dissection. Now conclusion. Short common channel common cloaca patient can be fairly managed with total urogenital mobilization with posterior sagittal anorecto-ureterovaginoplasty. The gynecological and sexual aspect could not be assessed at this point, as these would need longer follow-up and involvement of the other specialties as well. So these are my references, and thank you, sir.
Dr. Sharma, thank you very much. Any comments or questions from the audience?
There's one question and a comment. The question is, do you want to call it urogenital mobilization or urogenital separation? And the comment is, it is essentially a combination of PSAR, VUP, and total urogenital mobilization.
Yes, ma'am. Ma'am, please repeat. I don't understand your question.
I think you can see the chat in your Zoom. You cannot see? Could you click the chat in your Zoom, and then you can see the question.
Is it a mobilization of the urogenital sinus, or is it a separation of the urinary tract from the genital tract?
No, ma'am, there is no separation done between the urinary tract and genital tract. This is only a total mobilization of the urogenital sinus to the exterior, and because the wall between urethra and vagina is plane is very thin, and the injury to vagina or urethra is more likely to be happen if we go on separating between two planes.
Another question is only 2 out of the 6 patients had a stoma. Is that correct?
Yes, sir.
Only 2 patients had a colostomy out
No,
of
ma'am.
6.
No, ma'am. All patients had colostomy. Only 2 patients had decompressing. They had hydrocolpos in neonatal period, so they need that
Vaginostomy.
vaginostomy.
Okay.
Only
Thank
2
you.
patients. Okay.
Thank you.
Sharma, Dr. Sharma, thank you very much. Thank you. We have to move on to the final paper in this session. The paper number 35, presented by Dr. Shilpa Sharma. Please.
So I'll be sharing a rare case of caudal duplication syndrome with duplicated cloacal malformation. This is a very rare anomaly. The incidence is only 1 in 2 lakhs. We'll be sharing our experience with one such case who had come to us at 6 months of age. She was a product of in vitro fertilization. She had a healthy twin sister who weighed half her weight. At birth, there was no anal opening and no passage of stool. A divided sigmoid colostomy was done elsewhere on day 2 of life. The ultrasound and the echo was normal. This is what the anatomy looked like with 2 genitourinary tracts and 2 cloacas. The MRI was very confusing. It showed a blind ending rectum, 2 fluid-filled tracts opening into a common fluid-filled sac, communicating with the uterus and cervix, with a tract from the urinary bladder opening into the upper vagina. The dye study was also not conclusive, as it showed a blind rectum and a small tract. So in the outpatient, we did a distal wash with pressure, and we could demonstrate some amount of fluid in trickles coming out from the cloacas. A pan endoscopy was planned. On doing a pan endoscopy from the left side, we found the urinary bladder and the urethra from the right side. And on the left side, we entered the cervix and the vagina. We could not see the rectal opening even on pan endoscopy. So we moved ahead to an anterior approach, and recto-vagino-urethroplasty was thought to be done. The right extreme labia and the left extreme labia were left for reconstruction. We encountered 2 vaginal tracts which were approximated. There was a left hypertrophic clitoris which was removed. After removing this fat from here, we identified the rectum that was opening into the posterior vaginal wall. So basically this tissue of fat was stopping the rectum from giving anything outside. The urethra was on the right side and it was brought to the midline and stitched here. The vagina was on the left side. It too was approximated for both of them and brought in the midline. And the rectal pouch was mobilized and brought down, and both the sphincters were saved, one kept on the right side and the other on the left side. On post-operative follow-up, the colostomy was closed 10 months later. The baby passed formed stools 1 week after closure. At 1 month follow-up, she had mild constipation managed with laxatives. Now at a follow-up of 23 months, she is continent, passing stool once a day without any edema. She had always remained continent for urine. So here is a comparison of the pre-operative, operative, and post-operative follow-up now. This is what her perineum looks like. And she's quite equal to her twin sister who weighs actually 1 kg less than her. To conclude, caudal duplication syndrome in association with cloacal malformation is a complex anomaly. Waiting for some time for tissue growth gives a satisfactory cosmetic and functional outcome. Thank you.
Thank you very much. Fantastic operation. Any comments or questions from audience? Did you see the development of the pelvic floor muscle in this case, preoperatively or post-operatively?
The pelvic floor muscle was quite well developed. It was not that bad as seen on the MRI, but it was quite confusing because they could not delineate the anatomy properly for us. The bladder was shifted on the right side. The vaginal tracts were opening down, and because of that fat segment in the center, nothing could be delineated as such.
Do you think the patient with colloical malformation have better pelvic floor muscle compared to other high anorexia malformation anomalies?
It depends on the segment of the common channel. There's some who have a very good anatomy and they surprise us that they're doing well. And the others with long common channel, they usually do well, most of them. But the ones with long common channel in which the repair has not done properly, they have some problems.
Thank you.
And we also encounter pouch colon. So those with pouch colon do not do so well. They have
Thank you.
Thank you.
Alberto,
The
please.
Patients with double raphe and duplex systems, bladders and rectums and so forth, we have a series of those patients, and each case is different. Each case we studied in a very meticulous way, because sometimes they have two bladders and you wonder what to do about it, which one eliminate, which one you preserve. And sometimes the double raphe in the midline and the distance between one raphe and the other is very short, and you can remove all the tissue in the middle and bring everything together into a single one. But sometimes the separation is such that it's not possible to do that. So there is no single formula for the management of these cases with double systems. Each case has to be evaluated separately and make individual decisions. I enjoy your presentation, Shilpa, very good.
Thank you, Professor Pina. What I want to just discuss is that usually when we have the proposed anal opening, we go through midline. But in such case, you have two proposed anal openings. So we kept both of them. We didn't go through the midline of each, kept both of them so that whatever tissue is there will add to the continence. I had a worry that she might have constipation in the post-operative period, but she did well. Though cosmetically, she might have little extra tissue there, but it's been left there for now.
Shilpa, thank you very much.
Thank
so
you.
we are closing this session. Thank you very much for cooperation. Thank you.
Thank you. So we move on to the next session.
Yes, please.
Okay. Good afternoon, ladies and gentlemen.
Is Dr. Ramsamus there? He is the chair for the next session.
Yeah. Good afternoon, everyone. I'm here.
Yes, sir. Please start the session.
Yeah, Professor Intala, you have to start the session from the first case.
Just unmute my my computer. So good afternoon, ladies and gentlemen. It's a pleasure to chair this session with Professor Shamui. And we start with the paper from Italy, from Milano, from Giovanni Ricci Peditoni's group. This paper is titled Association between Hla variant and the course of ulcerative colitis in pediatric patients, a monocentric retrospective observational pilot study. And this is presented by Dr. Raffaele.
Good afternoon, everybody. Thanks for this great opportunity to share this research in this meeting. So the etiology of ulcerative colitis is only partially known and multifactorial, as we know, with immunologic, environmental, and genetic factor that influence the variability of presentation, the response of the treatment, and the disease course. We know that genetics plays a key role. In fact, in about 20% of children and adolescents develop the ulcerative colitis in this period. And across the age, there is a different contribution of biological networks in etiology, phenotype, and natural history. The early onset, as you see in the image, has a prevalence of a genetics factor more than the late onset. And we know that the HLA region is really involved in this process with up to 200 genes that are involved in the immune system. There are already studies that identified more than 200 loci associated with increased risk of developing the ulcerative colitis or the Crohn's disease. The aim of our study was to evaluate the association between different polymorphism in the HLA region, and in particular with the onset of ulcerative colitis in children, the need of more aggressive treatment as biological drugs or surgical intervention, and the clinical course measured with PUCAI, Parigi classification, and Mayo score for endoscopy. We focused on both class 1 and class 2 HLA. Previous study focused only on class 2, so this is, in our knowledge, is the first study focusing on both classes. This is a monocentric retrospective observational pilot study. So we included all pediatric patients with ulcerative colitis among our patient clinics, or adults with diagnosis performed during pediatric age in the time window between 2016 and 2019. In the phase 1, we gathered all the information from patient and the clinical course during the follow-up and the therapy applied. And after their consent, we started with the phase 2 that was taking a blood sample for DNA extraction. And we performed the HLA genotype analysis. After that, we performed the analysis of all the polymorphism HLA and the relation with the clinical course and the therapy. The statistical analysis was performed with the Fisher-Extas test, and the significativity was with a p-value lower than 0.01. This is our cohort of patients. We found 30 patients, some missed for moving to other places or refusing to participate. And a total of 23 patients were enrolled for the study with a small prevalence of female to male. 2 patients had to be excluded after the blood sampling due to the poor of sample that made it impossible to make a good genetic analysis. This is a follow-up where we take information running from a few months, just for the late patients included, to up to 12 years. And for all patients, we analyzed the clinical control, the examination, the need of endoscopy. Everything was done following the local protocol and, of course, the disease course trend. About the age of onset, our patients have an average of 11 years old, with only few patients younger and 1 patient 4 years old. The Hla variance frequency is the interesting point of our research. I'm just showing you the main results because we analyzed all the Hla region, was a very huge analysis. And what you see in this slide are that variants involved in the ulcerative colitis. You see, we made also a comparison between general population and our patient with ulcerative colitis. And with this variant, the PB104, DRB3, C and B, but majorly DRB302, showed an increased risk of developing ulcerative colitis up to 30 times. Then we divided our groups according to the therapy they performed during the follow-up. So divided in mild ulcerative colitis when they had only drugs as mesalamine and thioperin, and severe ulcerative colitis for the biological treatment or surgery. And again, the HLA-DRB3/2 showed to be related with a severe manifestation of pathology, up to 10 times requiring an aggressive treatment. And there is a subtype, the 01, that were more present in severe disease and showed to be 6 times up the risk to develop a severe disease. About the PUCAI score, we grouped patients in 2 groups according to the threshold of 65 for PUCAI that we as surgeons know as the threshold for surgery, so the severe disease. And again, we see that the DRB30201 is involved with the severe disease. About the age of onset, we divided group according to the age, lower than 10 years old or older, and we don't find significant differences in the allele frequency. Of course, we recognize some limitation of our study. First of all, there is a poor sample size, and secondary, it's very difficult encoding the HLA region due for some reason. It's extremely polymorphic, it's dense, and it is subject to linkage and disequilibrium effect. Of course, we know that this single gene we measure confers a small risk to develop ulcerative colitis, but there are a lot of other genes outside the HLA region that are involved. So it's important to perform a cross-analysis with these other genes. And in the end, also the cost of the genetic analysis of all the HLA region that is very high. So in conclusion, we see that the several allele of HLA region plays a key role in development of ulcerative colitis, increasing the risk of developing the disease and modifying its course and response of treatment. In our opinion, this gene could be used as a marker of disease course more than marker of diagnosis in the general population. That means that if you already know how will be the course of the disease, you can schedule a better therapy for these patients. But to make this conclusion, of course, we need more studies with a major sample size and better clarify the relationship between different genes and the genes and the environment. Thank you.
Thank you very much. This was very interesting. Could you tell me, could you use this as a tool to assess clinically the need for like therapy escalation and or even surgery?
Yeah, that's one of the points we discussed with the group. And actually, the problem are the cost of the genetic analysis. And with our results, we need to have a major cohort of patients with this genetic analysis to see if it's effective to schedule a different treatment according to the genetics. But according to the other genes involved, for example, we need to perform the Fibonacci correction to do Bonferroni correction, sorry, to better link the genes and the environment and all these stuffs to the disease. So it's a big study we need to go on, and probably also with a multicentric study, because there are also differences in the HLA expression in the population according to the place they are.
Any more comments? There's one comment from Professor Gupta.
Please unmute yourself, Professor Gupta.
Thank you for the nice presentation. Just was wondering if the study is reproducible.
Yes, yes, it is. We have a protocol, so is it possible to reproduce the study also in other places? Of course.
My point was that if such studies done somewhere else and also show the presence of the similar genes.
Yeah, that's the question, because as we said, there are also environmental factors that are involved. And when we analyze the HLA genes, we made it with the general population of the local population with our database. So it could be interesting to see if in other countries is the same results or different results, of course.
Thank you.
You're welcome.
Okay. There are no further questions. I give the mic to my colleague, Dr. Samui.
So the next speaker is from United Kingdom, Dr. Alison Campbell. He is going to talk on Masters of Phenotype Flip, risk of developing Crohn's disease following restorative proctocolectomy for ulcerative colitis. Dr. Alison, please. Dr. Alison.
Unmute yourself, Alison.
Ladies and gentlemen, thank you for this opportunity. We noticed unusually in our pouch patients that they didn't seem to go on to develop Crohn's disease like other people had been reporting following their pouch for ulcerative colitis surgery. In Newcastle, we offer restorative proctocolectomy and ileal pouch anal anastomosis for all our medically resistant children with ulcerative colitis. And since 1999, we've performed this surgery for 84 children with ulcerative colitis. Median age is 13 years, but we have done this surgery for children as young as 4 years of age. The first 25 cases were open, but we subsequently went on to perform this laparoscopically, although 5 out of 59 were converted to open. It's a hand-sewn intra-anal anastomosis. For children who come urgently for surgery, they will have it performed in 3 stages. They'll have their colon removed laparoscopically, and they'll then return for their second stage, where in the prone position, the rectum is removed, an ILL pouch is created, pouch anal anastomosis performed, hand sewn intraanal anastomosis, and covering ileostomy placed, with the third stage being closure to ileostomy. Obviously, in our children who are slightly more well, they're able to have their colon out and their pouch formed in the same setting. Of our patients, 3 were unable to anastomose because of cushingoid, and 2 of those ended up with a permanent stoma, though 1 was subsequently able to be anastomosed. Of the 85 pouches that we performed, 12 have been excised, and 3 of these patients have gone on to have revisional pouch surgery and remain in continuity. We looked at all our pouches that we excised. We didn't seem to have Crohn's in any of our excised pouches. All our patients are followed up by an adult general surgeon with an interest in this and will undergo every 2 or 3 years pouch surveillance. And there wasn't any Crohn's on long-term follow-up. Our patients have been followed up for up to as long as 20 years, although obviously some of them have only been followed up for 6 months as they've had their surgery in the last year. Of the 12 patients that have had their pouches excised, poor function, pelvic infection, some of the most common problems, fecal incontinence was almost a relative indication to not perform pouch surgery, as patients who had fecal incontinence pre-operatively tended to have fecal incontinence post-operatively and have their pouch excised. And disappointingly, within the last month, we've had 1 patient with cardiomyopathy who at 9 years post-pouch formation has developed ischemic bowel because of their cardiomyopathy and had a perforation within their pouch and had their pouch excised. But none of these pouches have had Crohn's on their histology, and none of our patients on long-term follow-up have had Crohn's develop on their surveillance biopsies of their pouch. And this obviously contrasts with the published literature. The only other sort of long-term follow-up in pediatric patients reported a 28% conversion to Crohn's on long-term follow-up. The adult peoples that I've included here don't have as long-term follow-up, but obviously have up to 10% of their patients converting to a Crohn's diagnosis having previously been ulcerative colitis. There's obviously a number of options for why this might be. It could be our pre-operative workup. It could be the willingness of our pathologist to come down firmly with the diagnosis, or it could be something else entirely. It could be the gut microbiome of our population. Is it our pre-operative workup? 3/4 of patients who go on to have a diagnosis of ulcerative colitis and pouch surgery were at their initial presentation thought to have ulcerative colitis. However, there were a number that we didn't initially think had ulcerative colitis, including one interesting case of a young teenager with a perforation who was initially thought to be a delayed presentation of Hirschsprung's disease. And in fact, on their first colonoscopy, around about the 50% mark that are diagnosed as having ulcerative colitis. We obviously don't stop there. Most of our patients undergo around about 3 colonoscopies. If the initial biopsy had indeterminate colitis, patients tended to undergo more biopsies and more colonoscopies and biopsies. However, we did have 2 patients who were initially indeterminate colitis and biopsy, unfortunately presented with a toxic megacolon and had ulcerative colitis diagnosed in the colectomy specimen, and therefore did not undergo a second colonoscopy. But all our patients had a histological diagnosis of ulcerative colitis before being offered completion in restorative proctocolectomy and pouch surgery. So in conclusion, from 20 years of performing restorative proctocolectomy for ulcerative colitis children in Newcastle, we have not seen a change to Crohn's diagnosis despite long-term surveillance. And this contrasts with published literature. However, as I've alluded to earlier, lifelong follow-up and pouch surveillance is necessary. It's important that you know who your pouch surgeon is as you progress on into adulthood. Thank you.
Thank you, Dr. Allison, for your excellent presentation. Actually, in pediatric ulcerative colitis, Crohn's disease is not uncommon after ileal pouch anal anastomosis. And chronic pouch inflammation often precedes the diagnosis of de novo Crohn's disease. You have shown results contrary to this. Very interesting experience, but what do you think is the reason for this different data from your center?
So as I've presented, we continued to scope and biopsy patients until we had a diagnosis. Unless they presented acutely, requiring their colon to be removed acutely, we did not perform colectomy until they had a diagnosis of ulcerative colitis. If they had their colon removed acutely because they were unwell, we did not proceed to restorative pouch surgery until we had a diagnosis of ulcerative colitis from the colon that had been removed. I guess it's that commitment to making sure that it is ulcerative colitis before performing surgery. However, I'm sure that's what many other people do, and so it may be something else that's at play. My colleague, the previous presenter potentially alluded to something quite interesting. Perhaps it is the gut microbiome.
Okay. Professor Intala, you are going to ask some question.
Yes, please. This is extremely interesting because our experience is the opposite. Sorry. This is extremely interesting because our experience is the contrary, and I think that we do the same amount of pre-op examinations as you do, but in our hands it's the incidence of Crohn's disease in the pouches is about 15%. But still, there are very few that have to be removed at the end of the day. In Finland, the incidence of Crohn's disease is increasing all the time. Is this the same in Newcastle area also?
I haven't specifically looked at the incidence of Crohn's versus ulcerative colitis. So though the incidence of inflammatory bowel disease seems to be increasing, I haven't specifically looked at whether there's more Crohn's developing rather than ulcerative colitis as such.
In Scandinavia, it is mainly the incidence of IBD is increasing rapidly, and most of the cases today are Crohn's disease. Although ulcerative colitis is increasing too, but not at the same rate.
Mm.
So if there is no question, is there any other question? There is no question in the chat box.
There is one in the chat box from Dr. Mansoor Sheikh. He's complimenting you for your presentation and asking, do you have any experience with ileoanal anastomosis?
We don't tend to offer ileoanal anastomosis for this condition. The gold standard in adult practice is to perform an ileal pouch anal anastomosis, and therefore we offer that gold standard because that's what we perform.
Thank you.
Thank you, Dr. Allison, for your nice presentation. Professor Intala, please introduce the next speaker.
Okay. This talk comes again from Milano and is titled Eosinophilic Colitis in Children, a New and Elusive Enemy. And this is presented again by Dr. Raffaele.
Thanks again. There is an appraising interest in eosinophilic gastrointestinal disorders, both in children and in adults. They represent a clinical enigma with evidence limited to a small number of report case series, and the pathogenetic mechanisms are mostly unknown. There is a prevalence of allergy and atopy, and what we know most about the eosinophilic esophagitis. What we are doing is a study about the colitis. This is because there are no guidelines for diagnosis, therapy, and follow-up. And there is also a problem about the threshold accepted for the diagnosis that's different from the esophagus, where we have a threshold. For the colon, normally there are some eosinophils living in the colon, and there is a high debate in how many eosinophils we have to consider pathological. So we try to find a possible correlation between the eosinophilic colitis and the associated disorder, the macroscopic findings and endoscopy, and the treatment and follow-up. We performed a retrospective review among our center in the last 5 years for all the children underwent colonoscopy. We included all the patients with colitis according to the Collins criteria with the number of eosinophils, and excluding all patients with inflammatory bowel disease or other pathologies causing hypereosinophilia. This is our results. We had a median age of 8 years, a slight prevalence of male in our population, and all the symptoms were chronic intermittent symptoms like abdominal pain, chronic diarrhea. Few patients presented the constipation or other symptoms like bleeding, weight loss, fever, and abdominal pain. It's interesting what we found about associated pathology. We have 14% of allergies. It's a prevalence lower than the other study published about. We have a higher prevalence of autistic spectrum disorder. About 44% of our patient was autistic and present eosinophilic colitis. It's also interesting there is not crossover within allergies and autism, so all patients autistic were not allergic, and the same for allergic patients. And the prevalence of autism is higher in our population with colitis than in the overall population. About macroscopic findings, we found usually normal mucosa, and the other findings are the lymphoid nodular hyperplasia in the mucosa with sometimes mucosal bleeding, edema, or polyps and erosion in those patients with a high number of eosinophils. In the last year, we tried to realize a score, endoscopic score, describing the endoscopy, assigning a score from 1 to 3. As you see, the main goal was to describe the hypertrophy of the nodular lymphs. We find a pattern that runs from spot nodularity to confluent nodularity that stop the vascular pattern. And the worst cases we had are endoscopic feature like EBD with chronic ulceration, edema, and phlegosis. About histology, it's interesting that all the reports speak about chronic inflammation with lymphoid aggregates, sometimes with microabscesses. And about the count of eosinophils, we see that the average is not always upper from the threshold we established with the Collins criteria. This is because to make diagnosis of eosinophilic colitis is necessary that only one segment has a value upper to the threshold. We, of course, understand there are some limitations of our study. For example, we were not able to analyze the treatment. We used both the therapy, the 6-food elimination diet, the budesonide, sometimes the mesalamine for symptom relief, but there was not standard protocol. And moreover, we had not enough subject to evaluate the responses to therapy because we have some patients coming from outside since we are a local referral center only for the endoscopies. Sometimes the families refuse to perform further investigation because children got healthier and so they don't want to perform another colonoscopy. In the older patient of this series, there were no awareness of the eosinophilic colitis, so even the caregivers and even other colleagues didn't propose to perform a control with colonoscopy. And some patients decided to turn to other centers. And this is a problem because of the symptoms that are chronic intermittent. So people is always running out looking for answers. and solution. So in conclusion, we think that eosinophilic colitis is a new challenging pathology that leaves us with a lot of open questions. For example, if we have to consider that limitation, the threshold we used, a normal threshold, or we have to lower this level. If we do so, for example, in our series, we could include like more than 100 children. We want to understand if it's possible to apply an endoscopic score, why there is this association with autism, and how to treat this pathology. Thank you.
Thank you very much for a very clear presentation. This is interesting because I have personally performed a couple of thousand colonoscopies through the last 30-40 years, and I have seen this condition maybe less than 5 times, even recently. Is it possible that the threshold is a bit too low, or do you have like, I haven't seen reports on this elsewhere. Do you think this is that is local disease, or is it could the like medication of autism spectrum patients could that cause this?
We don't know yet. We are deepening our knowledge. Since last year, we try to have a standardized protocol even for therapy and follow-up. And of course, I saw in this series that from just 5 years ago, there was less patients with eosinophilic colitis, probably because we were not looking at this pathology. And it's challenging to know everything. As I told you, we decided to use the Collins criteria that are mostly accepted for the threshold. But if we load this threshold, we have a lot of more patients that need to be treated. And another interesting point is the treatment. You know that the budesonide, the cortisone is the steroid is important to stop to reduce the eosinophilic count. We have some patients that use the steroid without benefit, but using the mesalamine, they have symptom relief. But we can't relate at this time if what is this mechanism and if the diet is working or not. So we need to go on with this research, and I hope to expose more results in the next meeting.
I would fully agree with you. There's a question from Prof. Puri.
Yes.
Very interesting study. I just wanted to know how many pathologists were involved in validating these biopsies or histology. I mean, when there were.
How many biopsy you mean?
No, how many pathologists? You know,
Oh, generally we have 3 pathologists from our hospital that works with our endoscopies, all the same 3 pathologists that read our biopsies.
Okay, thank you very much. This was extremely interesting. Prof. Samui will present the next presenter.
Next presenter is Dr. Christopher Ernest from Austria. He is going to talk on sport medical performance of adolescents following ARM repair, a prospective age-matched control study. Dr. Christopher, please.
Thank you very much, dear Chairman, dear colleagues. Thank you very much for the great opportunity to present our data here in the Pediatric Colorectal Club. We all know that anorectal malformations can have a major impact on the pelvic muscles, the spine, and the lower extremities. However, professional sports medical examinations of adolescents following anorectal malformation repair are lacking. So we aim to assess whether adolescents following anorectal malformation repair have impaired motor skills or decreased cardiorespiratory performance capacity. Therefore, we invited all our patients in our sport medical unit, where we take care not only of top athletes, but also of our patients with pediatric surgical diseases, so that we can detect their organ-specific deficits and offer them distinct physical training and targeted physiotherapy, so that our patients with congenital or acquired diseases can fulfill their dreams and become professional sportswomen or sportsmen like this young girl. Therefore, we enrolled a prospective study. We invited all children treated for anorectal malformation between 2000 and 2014, and we recruited a healthy age and sex matched control group. We assessed the specific features of anorectal malformations, the associated anomalies, the comorbidities. We classified our patients according to Crichton-Beck. We used the bowel function score and the quality of life. And then we used 2 sport medical investigations. The first one was a cardiopulmonary exercise performance test on a bicycle ergometer. We had a gender and age adapted protocol with a stepwise load increase. We gained lactate levels at the end of each step and calculated the relative performance capacity. The second test was the assessment of motor abilities with the standardized Total Koch test, which is frequently used in the Central European region and has 7 established and validated items and proves the coordinative and conditional skills of our participants. We were able to include 18 patients following anorectal malformation repair with a mean age of 13.6 years. There were 13 female and 5 male patients. The majority of our patients had a perineal fistula or rectovestibular fistula. We had 2 male patients with a rectourethral fistula. We don't know the exact location because this is more than 20 years ago now. 1 girl with a cloaca and 1 with an imperforate anus. Spinal anomalies occurred only in 2 patients. And when we compare our 2 groups, we found no significant differences in the body weight, the body height, the body mass index, the muscle mass, or the body fat. The fecal continence was an excellent and good bowel function in the majority of our cases. However, we found 2 patients with a fair outcome and 1 patient with a poor outcome. The quality of life was also good in the majority of our patients, and as we know from previously published studies, the quality of life correlated significantly with the bowel function score. When we look at the cardiopulmonary exercise performance, comparing our 2 groups, we found a significantly reduced exercise performance in our patients group. However, the performance capacity was lower in individual patients from all of our groups. Interestingly, also the 2 patients with the spinal anomalies had a normal or a good performance capacity. When we look at the motor abilities, all items related to the lower extremities and the trunk stability were significantly worse in our anorectal malformation patients group, such as lateral jumping, sit-ups, long stand jump, 1 leg stand, and push-ups. When we look at the Total Koch test, which uses a school grading system, the grades in the anorectal malformation group were significantly lower compared to an age and sex matched healthy control group. So to conclude, we found significantly decreased exercise performance in individual anorectal malformation patients. We found significant deficits in motor abilities in almost all our patients following anorectal malformation repair. So therefore, we need routine locomotor function evaluation and spiroergometry, even in patients with excellent functional outcome and even in patients without spinal anomalies. Only with these examinations we can detect the low performers and offer them targeted physiotherapy and targeted professional sports medical training. However, we need larger group and more data to prove our results and to find the low performers and support them so that they can do it. Thank you very much for your attention.
Thank you, Dr. Christoph. It's for your nice presentation. It's a very interesting study and it's well designed. But I have one question to you. Why do you think that lower abdominal surgery should have a long-term effects? Do you relate it with general delay in development and amalgamation with peers or specific to ARM surgery?
I think very good question. Thank you very much. I think that this might be due to our patient cohort following anorectal malformation repair. They might be afraid of doing much sports. They might have some limits. And even without spinal anomalies, there might be some limits to the lower extremities and the pelvic muscles.
I want to have some comment with Professor Pina. Sir?
So it's an excellent study, and hopefully we could repeat that with a greater number of cases, because 18 cases is a very limited, doesn't include the entire spectrum of anorectal malformation. If we include cloacal extrophies and we include patients with anorectal malformations, myelomeningocele, spina bifida, then all those, then the results are going to be more spectacular. It's a great effort, and we should continue doing this kind of studies. Again, for those who have the privilege of having many cases, this study must be done in a larger number of cases. Congratulations, and thank you for your study.
Thank you, Professor Pina. There is one more question to Dr. Christoph. How many of your patients had cardiac anomalies which could have biased your results?
There were no cardiac anomalies in our patients cohort from this study.
All these 18 patients. Okay.
Michael Hallworth wants to say something.
Yeah. Professor Michael Hallworth, please speak.
No, that's an error. I don't want to say something. I say hello to Christoph.
Hi, Michael. Nice to see you.
Yeah, Professor Gupta wants to say something.
I was just wondering, in all these cases, psychological impact is very important as they grow in the society, in the family, and all those patients growing up with surgeries done in infancy on anorectal malformations. Of course, the other extreme spectrum will have much more impact than the others, but still they suffer from some level of psychological deficit, inferiority complex. And this results into their overall performance, intellect performance, physical performance, and psychological performance. If this cohort of group of patient was studied from this angle.
Yes, thank you. Thank you very much for this comment. We found no significant correlation to the quality of life and our performance capacity. That's why I think we need larger patient cohorts so that we can control this as well. Thank you very much.
Thank you.
Thank you, Dr. Christoph. Now we will move to next is Professor Rintala. Please introduce next speaker.
The next speaker comes from Mexico, and this is and the talk is titled "Functional Outcome After Cord Detethering in Fecal Incontinent Patients with Anorectal Malformations." The presenter is Dr. Emilio Portilla.
Thank you, Dr. Rintala, and thank you to the scientific committee for permitting presenting this study. We have no conflict of interest in this study. And as we all know, tethered cord is defined when the filum terminal is abnormally fixed below L2. And when the patients start growing, there is a stretching of the cord, and it correlates to injury. And this injury forms what is known as the tethered cord syndrome, which involves lower extremity and affects also bladder function and bowel function. It is also well known that 36% of all patients with anorectal malformations will have tethered cord. And this is associated with poor prognosis for both urinary and bowel control. But to what extent, we don't know that yet. It is a very controversial matter. Evidence shows that cord detethering improves lower extremity symptoms, but as to what extent improvement involves bladder and bowel function, this is also not known. So we wanted to answer if cord detethering could improve bowel and bladder control in fecal incontinent patients with anorectal malformations. So in our methods, our study group was anorectal malformation patients with true fecal incontinence who were submitted to cord detethering in a 4-year period. All patients were over 3 years of age. The age were bowel and bladder control is expected, and every patient had at least 6 months follow-up. All patients were diagnosed through an MRI, even if they had a spinal ultrasound as babies. And then they were presented to the neurosurgery department when they follow the detethering protocol, which if any of the following was present, a detethering procedure was offered. If they have any lower extremity involvement, clinical or electrophysiological, if they have any bladder incontinence or urodynamic anomalies, and if there was true incontinence, true fecal incontinence. All of our patients in this group had true fecal incontinence before the procedure. Then we studied the functional outcome, sacral ratio, types of anorectal malformation, and type of colon motility. We defined the functional outcome as continence, being when patient was completely clean in the underwear without the need of enemas or intermittent bladder catheterization. Partial continence was with patients who were mostly clean in the underwear without the use of enemas, but occasional accidents were present. And patients remain incontinent when they still need bowel management with enemas or catheterization to remain clean in the underwear. In this picture, you can see how the filum terminale has a lot of tension stretching the cord. Just to remind that the filum terminale is mostly a scar tissue with blood vessels and usually comes with a lipoma. But there are normally not nerves in the filum terminale. So the procedure the neurosurgeons done is a microsurgical one. They perform a laminotomy at L5 level, and they expose the dura. As you can see, after the filum terminalis cord, there is a retaching of the cord, releasing all the tension. As you can see in the MRI on the left, there is a filum terminale stretching the cord, and after the surgery, the cord is released and swimming freely. So we had 27 patients regarding the type of anorectal malformations. Most of them were vulvar and vestibular fistula. And on the results regarding bowel and urinary control, all of our patients were incontinent, fecal incontinent, pre-detethering, and after the surgery, 5 achieved partial continence and 10 achieved total continence, representing 37%. On urinary control, we had 20 patients who were urinary incontinent, and of those 24 achieved partial continence and 8 achieved total continence. On the type of anorectal malformations, we just wanted to show the most represented ones, and those were rectovestibular fistula. We had 4 patients. Those were by far the most benefit of the cord detethering. On bowel control, 75% of them achieved total continence, 25% achieved partial continence. In bladder control, 50% total continence. The largest group we had regarding number of patients were the vulvar fistula, and they achieved bowel control in 37% as total continence and 12.5 partial continence. Bladder control was achieved in 25% of them. And the patients that did not improve at all were those who we define as undetermined, where the PSARP was done at another institution. They did not improve at all. As all of our patients were on a bowel management with enemas, we knew how their colon motility was prior. And those patients with hypermotility achieved total continence in 28% and partial continence in 14%. And those with hypomotility performed better, achieving total continence 46% and partial in 23%.
Emilio, we can't hear you. Please check that your mic is on.
Yes. Can you hear me?
Yes, we can.
Okay. Okay, sorry about that. So regarding sacral ratio, those with poor prognosis achieve bowel control in 40% of them. And we will discuss that later because this was a very strange and abnormal finding. Patients with intermediate prognosis achieve total continence in 40% and 26% partial continence, and bladder control 60% became total continent and 26 partial continence. And we only had 2 patients with a sacral ratio over 7, and one of them became partial continence and total continent and bladder control. The lower extremity symptoms, they dropped from 81% prior the detethering to 22%. So this was very important as well. So in the discussion, cord detethering can improve bowel function. Well, this is a very controversial question. As you can see in the literature, it goes all over the places, from 50% improvement described by Long to 0% described by Levitt. In our patients, we achieved partial bowel control in 18% and total bowel control in 37%. Regarding anorectal malformation site, rectovestibular fistula show the most benefit from the tethering, and those undetermined showed no benefit at all. We discussed that motility, patients with hypomotility perform better. This was expected. And those patients with a bad sacral ratio, we had 4 patients who achieved total bowel control. As mentioned before, this was completely unexpected. So we take a look at these patients thoroughly. 3 had a good prognosis. 1 was a bulbar, 2 were a vestibular, and 1 had a bad prognosis. It was a bladder neck fistula. We do not have an answer on why these patients improve. We can only speculate that these patients were teenagers and they became more disciplined in their diet and toilet habits. But that's as far as we can answer that. And patients with a sacral ratio over 4 had better outcomes as expected. So in conclusion, we had unexpected good results, and what we can say about this is that we think is that because we only performed surgery in symptomatic patients and a minimally invasive approach was done by the neurosurgeons, the tether surgery in our study showed remarkable improvement in both bowel and bladder control. Of course, larger studies are needed, but these are promising results. So thank you very much.
Thank you very much for a very nice presentation. Your presentation was a bit long, so that we have, unfortunately, we have time for only one question. Prof. Puri.
Very interesting, amazing, and unbelievable results. I was wondering, why did you not use some of the scoring systems like Rentala scoring system for continence, etc.? It would have been better to use one of those scoring systems to evaluate a continence.
Well, yes, of course, it would be better. We usually don't use those scores, but yes, I appreciate the comment.
Any one short comment from someone?
There are lots of questions in the chat box, Emilio. You'll have to go down and answer them. I can just pick up one. What is the exact age for tethered cord surgery? From Mansoor Sheikh.
We wait after patients are over 3 years of age, and if because that's when we expect bowel and bladder control. So we can see at that age if they are fecal or urinary incontinent. So surgery is offered after 3 years of age.
Thank you. Were the results blinded?
No.
Who assessed the results?
No. It is not blinded.
Okay.
Okay, thank you very much. Thank you very much. For the interest of time, we have to move on, and Prof. Samui will present the next speaker.
Next speaker is Dr. Jose from Mexico, and he's going to present a very interesting aspect after anorectal malformation repair, that is the quality of life in patients with constipation or fecal incontinence after the repair of an anorectal malformations. Dr. Jose, please.
Thank you for the opportunity. Very often, doctors think that patients with anorectal malformation with bad prognosis in fecal control will have a poor quality of life. Currently, the number of children suffering from a colorectal problem has increased. The bowel management program described by Dr. Peña is an enormous contribution that has improved the medical outcomes of these patients. Measurement of quality of life has emerged around the world to assess the multidimensional impact of a chronic health problem on children's overall well-being. The purpose of our study was to evaluate the quality of life in patients with anorectal malformations. The same interviewer conducted a random survey in patients with corrected anorectal malformations in the bowel management clinic. Patients were accompanied by their parents during the interview. An informed consent was obtained. Interviews were conducted from October 2018 to May 2019. The protocol was reviewed by the Research Ethics Review Committee. In medical records of patients interviewed was reviewed gender, age, type of anorectal malformation, and functional outcomes. Functional diagnosis was constipation or fecal incontinence according on type of anorectal malformation, perineum quality, sacral ratio, and spine. We also review the follow-up and presence of involuntary bowel movements even with the bowel management program. To know the quality of life, we use the PET-QL questionnaire. PET-QL is a modular approach for measuring health-related quality of life in children with chronic diseases. This instrument qualifies 0 to 100 points to assess overall quality of life and different areas: physical, emotional, social, and school functioning. 0 is the quality of life's lower value, 100 is highest. The questionnaire is different for children under 8 years old. It has 24 questions, and for all the children that 8 years old, it has 23 questions. Questions from younger children were answered with emoticons, as you can see. Each emoticon has a value for questionnaire records. The questions for older children were answered with a sentence with different value. We obtained the global and specific functioning score for each patient. We compare quality of life in children with constipation and fecal incontinence. We also compare the quality of life between patients the successful bowel management program and patients with involuntary bowel movement, even in the bowel management program. SPSS program was used for statistics. We collect information from 52 patients, 26 males and 26 females. The age range from 5 to 14 years. In the table, you can see the different types of anorectal malformations of evaluated patients. Follow-up since last surgery was an average of 53 months. The average of quality of life in our patients was 84 points, and the specific areas scores are shown in the table. We compare patients with constipation and fecal incontinence. We had 33 patients with constipation and 19 with fecal incontinence. No statistical difference between quality of life in patients with constipation and fecal incontinence was found. In the evaluation by specific areas, we only observed statistical difference in the emotional area in patients with fecal incontinence. We compared the quality of life in patients present fecal accidents versus patients without fecal accidents during the management program. We had 34 patients without accidents and 18 with accidents. We observed statistic difference between quality of life in patients with a successful bowel management program. Patients with accidents had a lower score. In the evaluation by specific areas, we found statistical difference in the social and muscular functioning. In conclusion, global quality of life in patients with anorectal malformations is higher when they have a successful bowel management program. Benign or complex anorectal malformations do not have different quality of life regardless of the functional outcome. Successful bowel management provides a better quality of life in patients with anorectal malformations. Thank you very much.
Thank you, Dr. Jose, for your nice presentation. I have one question. What are the details of the bowel management program you have used? And how was it managed differently between the two groups in your paper?
Can you repeat the question, Doctor?
What are the details of the bowel management program you have used?
The protocol.
Bowel management protocol.
We have patients with enemas or patients with laxatives.
And in two different groups with constipation and with fecal incontinence, it was different bowel management?
No difference between groups with enemas or laxatives. No difference in statistical difference in quality of life.
Okay, thank you. I want comments from Professor Pena.
Thank
you. First of all, congratulations to the group of Puebla, Mexico. It's a young colorectal center fully dedicated to this. And we have been following the trajectory of that center, and we are very proud of you. The details of the bowel management is, I mentioned that before. I cannot overemphasize the importance of bowel management in patients with anorectal malformations because it makes the difference between dirty patients incontinent and patients that are incontinent but clean. Completely clean 24 hours per day. And we achieve that by the use of an enema. But every patient needs a different type of enema because every patient has a different type of colon. So we start with a contrast enema, and then by trial and error, with using different ingredients in the enema, saline, glycerin, soap, until we find the enema that allows the complete cleaning of the colon and keeps the patient completely clean for 24 hours. Now, laxatives is only useful in patients that have bowel control and suffer from constipation. If we give laxatives to a patient that is totally incontinent, it will make the patient worse. So it's important to differentiate those types of treatment because the term bowel management includes many aspects, but in general, we talk about bowel management referring to the use of enemas. And I invite everybody to try the bowel management because it makes a big difference in the quality of life of patients.
Professor Pena, there's one question from the audience that it would be nice what fluid you use for bowel management program and how much and which tube and what caliber of the tube.
Qual tubo usa, qual fluido e qual a quantidade. Essa é toda na prática.
We use a Foley catheter and we inflate the balloon. You put the tube in the rectum, inflate the balloon, and then instruct the parents. Our nurses instruct the parents how to do it. The balloon is inflated with about 30 cc's of volume, and then the parents are instructed to pull on the catheter to impact the balloon in the anus, so to avoid the leakage of the fluid when they are administering the enema. And the formula of the enema basically is saline solution. But as I said, it's a big difference between a patient that has a very narrow spastic colon and a patient that has a huge megacolon. So the volume, everybody wants a recipe, like a kitchen recipe about the bowel management. There is no such thing. You must take the time to do it by trial and error, taking an X-ray film every day and see the clinical results. In the patient that has a huge colon, the patient most likely will need a lot of irritants like glycerin, like soap, and sometimes phosphate in order to make that bowel to contract and empty. In a patient, the real challenge is a patient that have a short colon or spastic colon, because those patients, the colon is very easily cleaned with pure saline enema solution, a small volume, because it's hyperactive. The main challenge is how to paralyze the colon, how to produce slow motion of the colon in between one enema and another. And for that we use Imodium, and we also use constipating diet.
Thank you, Professor Pina, for your nice comment on bowel management program. I think there is no more questions. Thank you, Dr. Jose, for your nice presentation.
Thank you, Doctor.
Rintala, please go ahead with other speaker.
I think I'm the next one.
Yes, you are the next one.
So if Dr. Pimentola can... Okay.
Yes, sorry.
No problem.
You can share your screen here.
Can you see my screen? Can you hear me properly?
Yes, continue.
Hello, everyone. We want to present... We want to present the case of a female patient, 50 years old, with the diagnosis, complex anorectal malformation, ileostomy at 2 days of life, and urinary incontinence. In the physical examination of her perineum, we observed this anatomy: an enormous central opening in communication with a large cavity with 2 types of mucosa. On the sides, 2 orifices corresponding to 2 vaginal introitus. We could see constant urine leakage from the central orifice. She referred regular menstruation, and she had imperforated anus. After complementary studies, we are going to try to explain her anatomy. In a perineal view, you can see the lateral orifices. They are her vaginas. The central orifice was composed by urinary mucosa in the anterior portion in yellow and intestinal mucosa in the posterior portion in brown. In this draw, you can see her proximal and distal ileum, the distal ileum ending with an ileocecal bulb. The pelvic cavity was composed with urinary mucosa in the anterior portion and with intestinal mucosa in the posterior portion. There was no colon. She had 1 vagina on each side on the perineal hole. We performed a posterior sagittal approach to separate the lateral vaginas from the central cavity. Then a laparotomy was required to finalize the separation of the vaginas. The central cavity was closed in its distal part, becoming a neobladder. The distal ileostomy was left as a Mitrofanov. The original ileostomy was not modified. In a third surgical stage, the posterior sagittal wound was closed and the vaginas were anastomosed to the perineum. In this draw of her post-operative anatomy, you can see her proximal ileostomy that was left untouched. The distal ileostomy was used to create a mitral Fanov mechanism, and the pelvic structure was closed to create the neobladder. Both vaginas were separated of the pelvic structure and approximated it one and sutured in the vulva. The patient had solid bowel movement through the ileostomy. She's dry with clean intermittent catheterization through the mitral Fanov. She produces monthly menstruation and is waiting to create a single introitus. This paper presents a picture of a patient very similar to our girl. So we classified she as a covered cloacal estrophy. This malformation is a spectrum, but they usually have low implantation of the umbilicus, separation of the pubic bones, and one big hole in the perineum. Thank you very much.
Unmute yourself, Risto. Professor Intala, you're muted. Please unmute yourself from the left.
Sorry. Thank you very much for this interesting case. Obviously, you changed the order of talks, but that's no problem. This paper is now open for discussion. There are place for a couple of questions.
There is a question from you from the chat box. Have you heard of pouch colon? Can this be a pouch colon variant?
We didn't consider it a pouch colon because she had a big hole perineum, a big unique hole in the perineum. So it is more similar in the classification to a covered cloacal estrophy, the spectrum, maybe the more complex one instead of pouch colon.
Thank you, Maria.
This is definitely the case. Professor Peña.
I want to emphasize the importance of the to suspect and identify this entity that we call covered cloacal estrophy. The only difference between this patient and an clear cloacal estrophy is that the abdominal wall is covered with the skin. And the key for the diagnosis is the fact that the pubic bones are separated, and you do that by palpation, you can feel that. Then the umbilical cord in these patients is implanted lower than normal. And then they have a single orifice in the perineum, that's why it's a cloaca, but it's a huge orifice. And there are the vaginas running in opposite directions, lateral. And be ready, because when you open these patients, you find that they have no bladder neck, and therefore the bladder is tiny, underdeveloped, and they will end up needing a bladder augmentation. And inside the abdomen, be ready, because you may find a pouch. It's just similar to what happens in cloacal estrophies. It's a spectrum that goes from 0 colon to a pouch, and different degrees of amount of colon. But these patients will end up with an ileostomy because of lack of colon. So, and it's very important to recognize it just by looking at the abdomen and the perineum of these patients. Thank you, Maria.
Yeah, thank you very much, Alberto. Thank you very much, Dr. Moreno. Prof.
I want to have some comment. Yeah, I fully agree with Professor Peña that you have a very high index of suspicion to diagnose covered cloacal estrophy. And in 2015, I think Professor Peña has published a paper where he has described 31 cases of covered cloacal estrophy. Okay, thank you very much, Professor Intala.
Yeah. So, Professor Nui, would you continue?
Yeah. So next speaker is Dr. Igenia, and from Russia, and she is going to talk on bowel management program for fecal incontinence, Russian experience. Dr. Ignia.
Yes, sorry, it's my turn.
Yeah, your turn, please.
Dear Chairman, dear colleagues, thank you very much for the opportunity to share our results of bowel management program in our hospital. We analyzed the result of bowel management program in the Moscow clinics, Speransky Children's Hospital, for patients with anorectal malformations, Hirschsprung disease, and spina bifida. And traditionally, our hospital, we usually had a lot of patients, most of them with anorectal malformations after surgery from another clinics with poor functional results. And we did different things, and we used different investigations, type of investigations and treatment for these patients. We used defecography and the barium enema and others. And the last year, we implemented the bowel management program from Colorado Children's Hospital, from Dr. Spenya and Bishops and all of their teams. And we just adapted this program for our hospital. First of all, we used lecture for parents, and we did it online, less than half in a year. We used inpatient protocol. And first of all, it was contrast enema with water-soluble contrast. After that, we started the enema training with Foley catheter and the inflating the balloon. The parents of the patients keep the defecation diary every day, and we control the bowel disinfection by X-ray. And after that, we offer the individual recipe for enema for each patient. And during the pandemic period, we switched from the offline lectures for parents when we described and when we discussed about the program, we switched on the online lecture, and we used some social media, and it was really convenient and useful for us and for our patients and parents. We have the video on YouTube about the bowel management, and nowadays more than 2,000 views. We performed some quiz for parents who listened the video, who saw the video, and 26 respondents from 13 regions of Russia. You can see green on the map. Answer the questions, and most of them are interested in this program. And it's interesting, the 80% prefer the online format for this comprehension for parents. We analyzed results of 27 patients, the median age 5.5 years old. Most of them had anorectal malformation and the spina bifida. And we used the contrast enema like a first step. We interested the anatomical features of the colon, and we detected 10 children with dilated colon. We made the template for defecation diary where parents write about how the enema process, what is the enema process, did they have leakage, and how many stools they received, and they were accidents or no, and others. And after the discharge, they continued to write this information and send it for mail for us. We consider the good results when there is no accident after the enema during 24 hours, and there is no any contrast in the colon on the X-ray after our enema. And this picture, we share these pictures with parents. We show them to parents because it's really important because when the parents of patients saw that after defecation, a lot of contrast in the left colon, they understand why we increase the volume or why we add the irritants, and it raises the compliance and leads to better results. Successful results was in 22 patients, 3 we lost follow-up, and all of them were clean stool between the enemas. And it's interesting that we thought that children with dilated colon needed irritants in the recipe, but we saw that 13 patients, and most of them with spina bifida, did not have dilated colon, but they needed glycerin or more concentrated saline solution. And it's really interesting why it is. And in the discussion block, we can say that there's a lot of types of bowel management for children and for adults. And actually in Russia, this is a typical term, the bowel management for Russian doctors. We usually use the term rehabilitation. And I think it's a really broad concept, and the bowel management, the name of this program, it's more convenient, and it's really interesting, and it's new for our parents, but they like it because we think the name gives more hopes, the bowel management. And the second one, during this program, we understood that the first stage, the patient conference or lecture for parents, it's extremely important for successful result, because most of patients, especially parents, the children with spina bifida, did not understand why they need to do the enemas every day if their children have the fecal incontinence. And I repeat about the severe hypermotility in children, colonic hypermotility in children with spina bifida, and it's interesting why they did not have the dilated of the colon. And actually, Dr. Bischoff and the colleagues published some results, something like this 2 years ago. We saw the same thing. And if the glycerin did not work in these cases, we increase the concentrate, they use 3% of saline solution with very good results. And in conclude, in our patients, enema was effective for 82% of children. And I repeat that we need to use social media and online conference to do the information about this program for parents and about the conditions of their children. Thank you very much for your attention.
Thank you, Dr. Eugenia, for your nice presentation. Yesterday, in guest lecture given by Professor Pina, we heard that only 25% of the patients of ARM are continent, and rest out of 75%, half of them are having some problem. So with this statement, we can understand the importance of bowel management program. And thank you very much for elaborating this bowel management program in Russia by online education to the children and their parents. Now there is one question. Have you tried bowel management program with PEG?
Actually, for children with anorectal malformations and Hirschsprung disease, we do not use the PEG because it's really bad results. They have a huge pseudo incontinence because they need to quick move of the colon. But in patients with spina bifida, sometimes for smoothing the stool, for good results for enema, we added sometimes a little bit of PEG.
Another question is there any incidence or risk of hypernatremic dehydration with 3% saline?
3 or 4% of saline solution, we thought about it, and actually we detect the biochemistry, the blood samples for some children. And we told the parents about that they need look at the blood samples about after 1 month after starting this enema, and there is no problem yet, and I hope we wouldn't have it in the future.
Okay, Dr. Andrea, please.
Yes, I just want to congratulate Dr. Eugenia. We are extremely proud. We have many visitors coming from abroad, but it's not easy to go back to your country and implement such a big change. So I think we've been watching her and we've been impressed by how strong and positive her changes have been. So congratulations. I think bowel management, it should be mandatory for every place that operate patients with colorectal conditions.
You have a long way to go, because in the human beings are characterized by something called resistance to change. And but it's like a crusade what you are doing, but you are going to be successful, and many, many thousands of Russian children will benefit. Congratulations.
Thank you very much. Thanks.
Thank you, Eugenia, for your nice presentation, and congratulations from all of us.
Thank you.
Thank you very much. Professor Intala, you can go ahead with the last speaker.
Yeah. This is the last talk of the session, and it's titled Gracilis Muscle Transposition in Children with Anal Incontinence, Post-Trauma and Post-Anorectal Malformation Surgery. This is presented by Dr. Singh. Please.
Thank you. A very warm welcome from India. And today we are going to present our experience on gracilis muscle transposition in children with anal incontinence, post-trauma and post-anorectal malformation surgery. So it was Pickrell in 1952 who was first to use gracilis muscle transposition in the cases of trauma. And in anorectal malformation, the gracilis sling was first introduced in the year 1980 by Common. Our aim was to study the long-term results of gracilis transposition for fecal incontinence of varied etiology. We operated 21 children with gracilis transposition between the year 2007 to 2018, and their median age was 4.6 years. The demography, etiology of incontinence, clinical profile, and operative intervention were recorded. Continence status before and after the gracilis transposition were assessed clinically. A follow-up was done from 1 year to 12 years, and they were assessed clinically or by telephonic conversations with the patients or the caregivers. So to start with the technique, why gracilis? It is the most superficial muscle in that aspect of thigh, good in the length as long as the thigh. It is broad above and narrow and tapering at its lower end, which leads to easy mobilization, and neuromuscular bundle enters at a very high level in the muscle, which again helps in the easy mobilization of the muscle. So the patient is laid supine and the legs are abducted and the thigh is externally rotated. 3 vertical incisions are made along the axis of the thigh. We can see those 3 incisions, and the muscle is bilaterally mobilized per the requirement. So in the next stage, the vertical perianal incisions are made at 6 and 12 o'clock, and the gracilis is moved to the subcutaneous tunnel created. The last step is the fixation. The gracilis muscles are fixed to the ischial tuberosity. The gracilis tendons are delivered in the wound and fixed to the adductor longus tendon. And the procedure is again repeated on the other side also. So to illustrate our 2 cases of different etiologies, our first case is of a 4-year-old girl of a cloaca. She presented to us after repair with anal prolapse, fecal and urinary incontinence. The MRI showed dysgenesis of sacrum and coccyx and deficient external sphincter. Again, she underwent this procedure. Bilateral gracilis were mobilized. The gracilis thread we can see in the next image around the anus. And this is the post-op normal looking anus. Another case of an 8-year-old girl who met in road traffic accident. She met extensive degloving injury of the perineum, the vulva and the rectum. There were multiple bony fractures, prolapse of pelvic organs were there. And initially she was managed with a debridement, SPC, a colostomy, multiple skin graftings. Further, the release of vagina, rectum and the bladder was done by a deep pelvic dissection. Later on, a perineal soft tissue and floor reconstruction was done by myofasciocutaneous right rectus abdominis flap. And a rectoplasty was done along with vaginoplasty, and the anal sphincter was reconstructed using the right gracilis, as you can see in the images. Here are the results. The cosmetic results were also good, and the child could walk, as you can see. So going to our results, we operated 21 total cases, including 16 boys and 5 girls, 16 cases of anorectal malformation, 5 cases were of trauma. In 16 cases, bilateral gracilis was used. All the cases were performed under covering colostomy, while in one it was not required. In the complication, one child had perineal skin dehiscence and mucosal retraction. However, it healed with regular dressing. All the cases attained social continence. 2 cases had natural bowel movement, and all are fully continent, and rest of them need bowel management program. So we conclude that gracilis transposition provides passive outlet grip, which prevents the leakage and provides social continence to these patients. It can't substitute the normal sphincter mechanism. However, bowel management program is still required for diaper-free life and is effective in the long run. Thank you.
Thank you very much for a very clear and nice presentation. I have personal experience on this from the 80s, a little less than 10 cases of anorectal malformations, and my experience was not near so good as yours. However, we have done this in some trauma cases later, and in these cases the outcome has been good because these patients have had they have had normal sphincters to augment with the gracilis. Would you comment on this?
Sir, actually, our concept of providing the augmentation using the gracilis is based on more on mechanical continence, providing it is a mechanical resistance to the incontinence rather than giving a dynamic one. So it was the mechanical kind of obstruction given by the muscle, which made it quite successful to child to prevent the patient to prevent the incontinence, and it helped.
Can I comment on this, respected chairperson? I'm Dr. Satish Agarwal.
Yes.
And Gaurav is my resident who has presented this paper. The idea of using a gracilis came up because many of these children who are especially operated elsewhere with bad technique, as you would have noticed, a gross prolapse in the first child that Gaurav showed, and the muscles are hardly there. So even if we employ a good bowel management program in these cases, because most of them have spastic colons, they keep on leaking every time. So because there is no outlet resistance, and that we assessed as the main reason for their incontinence. And once we augment the outlet resistance by a mechanical kind of tight wrapping by the muscle, then it prevents leakage. Of course, in such a situation, we have to use a very effective bowel management program with the help of intracostal tubes and not a simple Foley catheter, because the Foley catheter can be used to instill fluid, but it will not allow it to come out by itself because the outlet becomes narrow, because it is gripped by the gracilis muscle. So we have to make a modification in the bowel management program. About the cases of trauma that have required this operation are the ones who have lost their external sphincter in the trauma. The patients in whom there is a bit of external sphincter still left, we have tried reconstructing the sphincter and approximating the 2 edges. The last girl that Gaurav showed was extensive trauma in the perineum where genitourinary tract, bladder, vagina, and rectum, entire thing was involved. And that child is a beautiful example of how an artificially created sphincter by gracilis can provide them social continence. Thank you.
In our experience, the problem with the gracilis muscle is that the initial tension or of the so-called this artificial sphincter is very good, but it wears off by time. So in like 5 years' time, it's the sphincter tension is very low.
I think the answer to that is we must start using dynamic gracilis. We must evolve ways and means to keep the resting tone of the muscle high. And I think a lot of work is being done on creating a dynamic gracilis sling. But another aspect for the technique is I agree fully with you that if you leave it loose, then the purpose is lost. That is why we do both the gracilis together, both the gracilis, so that the wrap is quite long and circumferential, and it's really tight. I mean, when I make the sutures, I put a small size Hagar dilator to make sure that it is tight enough, and that's the key in the technique. But yes, long-term results and long-term follow-up is very essential in such cases. Thank you.
One last comment, Michael Herbert.
Thank you. I fully agree with your authors that it is the resistance that makes the difference. We did also gracilis surgical procedures many years ago, and then we moved to the implantation of palmaris longus, which was presented first by Swedish colleagues, and we did that to a few patients. The most interesting experience for that was that the patient who got this palmaris longus transplantation, that they told us already 1 day, 2 days after surgery, they now can feel stool. And that is important to get, to achieve cleanness. So it's the same probably with your gracilis. It is a mechanical resistance and they feel stool. So they can react if they feel stool.
Exactly. Thank you so much. That brings us to another question. Has anyone used artificial sphincter, the AMS sphincter that people use for urinary incontinence? Has something of that sort been used by anyone?
Yes. Yes, let me say, first of all, we must remember that to have bowel control, we need 3 important elements. Number 1, sensation. You have no sensation, you can have the best sphincter, you keep passing stool because you don't feel that you're passing stool. Number 2 is sphincter, and number 3 is motility. Patients with unrectal malformations have deficiencies in those 3 areas. The muscle as well as artificial sphincters only are referring to the sphincter, but you don't control motility and you don't control sensation. Yes, we tried artificial sphincters. The type of sphincter that we use for the urinary tract, we did it in animals, in pigs. And yes, you activate the sphincter and then they don't pass stool. But then you deactivate the sphincter and they don't pass stool either. So that this is a very old procedure. We are very skeptical about that. I understand that you did a major operation that you show us, but we have seen many with gracilis muscle, they are totally incontinent.
Okay, thank you very much, Alberto. I thank all the speakers of the session, and we move on to the next session, the session number 6.
Professor Intala, I want to say something to you. I feel privileged today for chairing this session with you.
Thank you very much. Same to you.
And thank you very much. And I want to thank Professor D.K. Gupta also, and Professor Prem Puri, Professor Pinia for this excellent comments and then good support to all. Thank you very much.
Thank you, Professor Ram Samuch from Chandigarh, India, and Professor Isturintala from Finland. It was an excellent session. We move on to the next. I now invite Professor Louis de la Torre from Denver, India, from Denver, USA, and Professor Roy Chaudhary from India. Welcome to the session.
Thank you very much. Thank you for the invitation to coordinate this last session. Dr. Roy Chaudhary, you want to start presenting the first paper.
Yeah, sure. Welcome everyone. The last session, although may not be the least, because I see a lot of interesting papers, interesting techniques going to be described in the next hour and a half, though we are starting a bit late, but I hope we'll keep everyone awake through the session. So let's move on to the first paper of the session. The first paper titles Detubularized isolated ureteral sigmoidostomy, a continent diversion, Atta pouch by Nehal Shah. Please go ahead. Dr. Nehal, up to you. Can you start sharing?
Unmute.
We can see your screen. Please unmute. Go to the slide.
Unmute. Yeah. Can I start?
Sure.
Make it a slideshow, please.
Yes, I have made it a slideshow.
Your type starts.
Greetings from the KEM Hospital, Mumbai. I am presenting a case where a detubularized isolated ureterostomy, a continent diversion, also known as Atta pouch, was used in a patient with cloaca. She was a 4-year-old female child when she presented to us. She was operated outside with PSAR VUP with a diversion in a single setting at the age of 2 months. And 1 month later, stoma closure was done. Now at this age, she presented to us with total urinary incontinence and severe perineal excoriation. An otherwise girl who loved going out, attend school, play with friends, was socially restricted due to constant urinary leak. To her fortune, she was continent for stools. On examination, her general condition was good. Perineal examination showed, as in the photo, a severe single large cavity in the introitus with skin tags and severe perineal excoriation. Her neoanus was preserved with normal anal tone. With this history and clinical examination, we evaluated her with a genitogram which revealed a small capacity bladder and 2 hemivaginae. We also did a cystogenitoscopy in this patient, which showed 2 lumen deep in the introitus lined by excess skin, absent urethra, small capacity bladder, ureteric orifices were not appreciated. 2 hemivagina were seen with separate cervix in each. Since the ureteric orifices were not seen, we did a CT IVU and MRI of this patient, which showed us a left ectopic malrotated kidney and a bladder which was distended, communicating with common urogenital cavity. In the view of these doubtful findings, we also did a diagnostic laparoscopy which showed us a small bladder capacity and bilateral ureters which were coursing behind the uterus on either side, but they were not traceable throughout its extent. Now, with all this information, we faced the task of deciding what would be the best we could offer the patient, considering the problems like large cave-like introitus, absent urethra, small capacity, open bladder, no bladder neck, 2 hemivaginae which were receded, fibrosed perineum, scarred perineal body. Fortunately, as a silver lining, we had a continent rectum. That we considered a complete perineal reconstruction followed by bladder augmentation with or without a bladder neck closure, a continent pouch or ureterosigmoidostomy, the conventional or the modern. Out of many modifications that are described in literature, one of which is described by PGI Chandigarh in India, we decided of going ahead with detubularized isolated ureterosigmoidostomy, which is also known as Atta pouch. This procedure was first described by Dr. Atta et al. From Egypt in 1996 for the patients of carcinoma bladder after radical cystectomy. He reviewed his results almost 18 years later in 2014. The principles of this procedure are detubularization of rectosigmoid colon, abolishing the RAIR, intussusception of the terminal colon into the pouch, implantation of ureter using the nipple technique to prevent the reflux, and minimum colonic surface area that is exposed to urine. After detailed counseling session with parents and child explaining the options, consequences, and preferences, patient was started with for the preparation with serial installation of increasing amounts of saline into the rectum for approximately 6 months to ensure the continence for liquids and improve the capacity. At the end of which she was able to retain 350 to 400 ml of saline for 30 to 35 minutes. She was also started on regular renal exercises. Anorectal manometry was found to be normal. So we headed with a exploratory laparotomy done by a phalangeal incision. Ureters were identified, disconnected at the vesical end, as we can see in the photo. We can also see a left-sided ectopic kidney. The left colon was dissected up to the splenic flexure and the sigmoid brought down, forming an inverted U-loop of rectosigmoid. Anterior rectotomy was done on the antimesenteric side. The detubularization of the rectosigmoid colon was done. The posterior edges were anastomosed, forming the posterior surface of the pouch. Here we can see a red rubber catheter is going into the descending colon. Ureteric reimplantation was done using the nipple technique to prevent the reflux. The left colon was fixed to the pouch in the line of the anorectal canal and the anterior surface of the pouch was closed. 2 5 French IFT were placed as ureteric stents and a rectal tube was placed which was brought out per rectally. The post-operative period was uneventful. The patient was discharged on chemoprophylaxis and counseling the parents for lifelong follow-up. On follow-up, at 2 years today, she is off diaper, dry, has no excoriation, no foul odor. She experienced physical well-being, participation in daily activities, school environment and performances, better relation with peers, and self-perception and psychological well-being. We'll keep surveillance on this patient doing a renal function test, blood gases, ultrasound KUB, and yearly sigmoidoscopy. So a uretrosigmoidostomy has rekindled the interest in recent times considering the modifications that are described. Using the modifications, we can separate the urine and feces. The low pressure large volume reservoir is formed, which avoids frequent emptying due to colonic overload. We could minimize the surface area exposed to the urine, which reduces the metabolic complications and delays the carcinogenesis. Using the nipple technique, we can prevent the reflux and reduce the risks of pyelonephritis. Dr. Atta in his paper had faced complications as described in the table here. However, the results were satisfactory continence with satisfactory emptying habits. Patient could tolerate the full pouch completely for about 30 to 35 minutes with no leak and can discriminate between urine and stool evacuations. So we were left with the future options for perineum as leave as it is or do a complete perineal reconstruction. Thank you.
Thank you, doctor, for nicely presenting this technique of Atta pouch in a child who would otherwise be completely having urinary incontinence. 2 comments.
Yes,
one is that we see congenital pouch colon girls with similar kind of problem of a small bladder and very narrow or very wide bladder neck leading to complete urinary incontinence. But in those cases, the colon is generally not available to make a Atta pouch. Whereas in this case, you are fortunate to have a colon available to make the Atta pouch, as well as you are fortunate to have a cloaca child with complete fecal continence, which has given you the opportunity to apply this procedure.
Yes.
So with that, I open it for any comments or questions. Are there any comments or questions? I can't see anything in the chat box.
There is none in the chat box.
From my
Michael.
Dr. do you have anything to say?
May I ask a
No,
question?
Dr. Michael has a question.
Sure, Dr. Michael, go ahead.
Thank you very much. I enjoyed your presentation very much. It's an excellent result. Congratulations. I just have a question. When you went over the literature, did you came across Gersuni's method? He implanted, because we did it many years ago for a similar case, he implanted both ureters in a piece of colon and made a retrorectal pull-through so that both openings are appearing, the pull-through colon opens behind the anus, but both go through the sphincter. Came you across this method? Gersuni was his name. And it worked also nice. So basically, but congratulations to your case.
Yes, sir.
Dr. Bishop, go ahead.
Yes, congratulations on your result. I just want the audience to remember that I think this is a very unique case. Most patients with anorectal malformation, they cannot control liquid stool. So it would be very hard for them to control urine. And I think nowadays, Uretrosigmoidostomy has been used for many years, and I think nowadays most people would prefer closure of the bladder neck and Mitrofanov with or without bladder augmentation, depending on the size of the bladder. But again, I know this is a unique case, but I just want to emphasize in patients with anorectal malformation, I'm happy it worked in this case, but most patients cannot control liquid stool. So it would be very hard for them to control urine.
Yeah, thank you, ma'am, for this comment. Very well taken. Difficult situation, but in this particular case, very well managed. So there are different techniques one need to apply as the case demand. Any other comments in the chat box?
Dr. Ravi wants to ask if it is applicable in acidotic patients.
So we had in this patient also one episode in which there was acidotic VBG. She was readmitted for it, but she just needed a oral dose modification, titration of sodium bicarb. Else the patient was okay. Yet for further studies, we'll have to get more patients so that we can generalize the things.
There's one last comment from Dr. Patra. The other name for this procedure is a rectal bladder. It's just a comment. So, thank you.
Sure,
Thank you
rectal
very
bladder
much.
can be made various ways. So this is one of the ways to make it. Shall we move on to the next?
Sure.
Okay, we can move to the next.
Thank you, everyone.
Of course. So the next paper is in number 47. The Meyer-Rokitansky Kosterhauser syndrome associated with anorectal malformation, a single center experience, and Dr. Charu Tiwari is going to present. Go ahead, please. Is Dr. Tiwari?
Yes, sir. Yes, sir.
Okay.
Am I audible?
Yes, you are, and we can see your screen. Please go ahead.
Yeah, you are.
Okay. Greetings from India. I'm going to present Marquette syndrome associated with anorectal malformation, a single center experience. Sorry. A female neonate with 2 openings in vestibule and an absent anal opening strikes 4 differential diagnoses in our mind. The first is ARM without fistula, which is common in Down syndrome. And the second and most controversial is the rectovaginal fistula. The third is vaginal agenesis with vestibular fistula. And the fourth is a common urogenital sinus with vestibular fistula. Marquette syndrome is inhibitory malformation of Mullerian ducts, clinically present with absence of vagina and varying degrees of uterine and cervical agenesis. Ovaries are normal and karyotype is XX. Various classifications are there and associated extragenital malformations may be present. Association between ARM and Marquette syndrome is not new, but however, the available literature shows scattered case reports. There are only 2 big meta-analyses which have been recently published. Exact incidence is not known and varies from 0.5 to 16.3%. Most reported is with association with vestibular fistula. The varying age of presentation is common in our country, the developing world, and there is no definite algorithm for optimum management, and there is a lot of psychosocial impact. With this, we present our study with aims and objectives to study the association of Marquette syndrome in patients with female ARM, associated congenital anomalies, diagnostic investigations, intra findings, procedure done, and follow-up. It is retrospective view of female patients with an established diagnosis of ARM and MRKH done over a 10-year period from a single center. Out of 878 female patients treated with ARM, 25 patients had MRKH syndromes. The data were obtained from patients' records and analyzed. So we had total 878 female patients treated over the 10-year period, and associated MRKH syndrome was seen in 25 patients, which turns to be 2.8%. With vestibular fistula, we had 11 patients out of 724, which is 1.5%. And with cloaca, we had 14 patients with MRKH syndrome out of 122 patients, which marks the incidence as 11.5%. Now, cloaca with MRKH syndrome, we had 14 patients. I will be describing them first. We had neonatal presentation as well as referral after diversion colostomy done elsewhere. 6 patients presented in neonatal period and underwent transverse loop colostomy. Associated anomalies were seen in many patients. 4 patients, pre-op diagnosis was made with MRI with vaginal agenesis and hypoplastic uterus in 2 patients and absent uterus in 2 patients. Common channel length was more than 3 centimeter in 5, and diagnosis was made intraoperatively in 2 patients. The diagnosis, the patients in which diagnosis was made underwent sigmoid vaginoplasty and PSARP, and 1 patient is awaiting definitive repair. Median follow-up of 32 months. The complications are fecal incontinence in 2 patients, constipation in 1 patient, vaginal stenosis in 1 patient. However, these are all undergoing dilatation and bowel management program. The patients who were referred from outside had sigmoid loop colostomy done. Hence, we proceeded with ileovaginoplasty and PSARP. In 1 patient where the diagnosis was made intra-op, the patient was managed with PSARP only, and she is awaiting vaginal reconstruction. 2 patients are still awaiting surgery, and the median follow-up is 12 months. 2 patients had fecal incontinence, 1 patient have constipation. However, they are being managed with bowel management program and kept on rectal washes. MRKH with vestibular fistula was seen in total 11 patients. In neonatal presentation was, we had neonatal presentation in 5 patients. All were kept on rectal washes as they were deflating well. Pre-operative MRI was done in 4 patients and suggested vaginal agenesis in all patients, hypoplastic uterus and absent uterus in 1 and 3 patients respectively. Intraoperative diagnosis was made in 1 patient, associated anomalies renal in 5 and cardiac in 3. Thus, atypical MRKH syndrome was seen in most of our patients. The procedure was done with PSARP with ileovaginoplasty in 3 patients, PSARP with retention of distal fistula as vagina in 2 patients. Median follow-up of 36 months, vaginal stenosis is seen in 1 patient who is undergoing dilatation. Constipation is seen in 2 patients who is under bowel management program. In patients who were referred after sigmoid colostomy, in 3 patients, we proceeded with PSARP and ileovaginoplasty. At median follow-up of 25 months, constipation is seen in 2 patients and vaginal stenosis in 1 patient. There were 3 patients in whom PSARP was done outside and the diagnosis of MRKH was missed. 2 of them presented with anal stenosis and underwent anoplasty for the same, and they all are awaiting vaginoplasty. MRI was done in all, and absent uterus and vagina was seen. In median follow-up of 12 months, there are 2 patients who have constipation and still being managed with bowel management program. Association between ARM and MRKH syndrome, the current scenario is that there are no RAS series and maybe the cases are underreported and underreported. We found incidence of 25 out of 878 in 10 years, which accounts for 2.8%. We found cloaca more than vestibular fistula, which is in contrast with commonly reported as the vestibular fistula. Early vaginal reconstruction with bowel we prefer because there is a lot of retrusion rates. The people lost to follow up and don't turn up. Even the telephonic number which they give is either not reachable or switched off like that. And fertility issue and psychosocial impact is there. And for this, I recommend multidisciplinary approach with psychosocial counseling. Uterine transplant may be the way forward, but it's far too way forward. So I will conclude that this association is rare, missed, or regional. I cannot comment, but incidence may be more as seen in our series. Better facility for MRI in infancy. We could diagnose MRKH syndrome preoperatively and plan the procedure after proper counseling of parents. Initially, in old, means in early, in this 10 years, we could do MRI for only last 3-4 years. Before that, we used to have inadvertent that intraoperatively we found that there was no vagina, and then we could not plan properly. And availability of small cystoscopes to better delineate the common channel length, especially in government setups. Proper workup, early reconstruction, and parental counseling is essential. Multidisciplinary management is recommended. Thank you.
Thank you very much for this nice presentation. There's questions in the box. One of them is, how old are you? Your two patients with rectal fistula, left has vagina, and how their continence is.
Actually, sir, in patients where the distal fistula was left as vagina, they are only having fecal incontinence. Hence, we decided to go with PSARP with normal rectal reservoir as rectum and ileovaginoplasty.
Thank you very much.
This was
Dr. Bishop?
Can I make a comment?
Yes.
Yeah.
I just want to comment that I personally don't like to use the terminology Meyer-Rokitansky with anorectal malformation, because if we think about patients with Meyer-Rokitansky, they have absent vagina, sometimes with absent uterus, but it's a condition that you can deal later in life. The majority of these patients will get a vagina just from dilation of the vestibule because they have that normal space where the vagina is normally located. Now, when we talk about anorectal malformation, it's a completely different scenario. In a patient with vestibular fistula with absent vagina, you have to separate the rectum exactly where the vagina will be located. It will be way harder to do this vaginoplasty later in life, having the rectum having scar tissue in between. The same thing for a cloaca patient. If you underwent through the separation of the rectum, bladder, it will be way harder to later do this vagina. So I think in patients with anorectal malformation, the vaginal reconstruction should be dealt at the same time as the anorectal malformation because it's part of the operation.
I completely agree, ma'am. That's why we recommend planning with MRI, pre-operatively full planning. We did in cloaca patient, 4 patients with cloaca. We proceeded with sigmoid vaginoplasty and PSARP at the same time. We had encountered severe difficulty, severe scarring while performing on patients who had been previously operated with pull-through, and then we are going to have, make a new vagina. This is completely, that's why it's very essential that MRI should be done and proper planning and proper should be done. We even started doing examination under anesthesia and cystogenitoscopy as a separate procedure from the main definitive surgery.
Yeah, Dr. Charu.
Yes, yes.
You mentioned hypoplastic uterus in few patients, and I wonder what you did with them. When you do a bowel vaginoplasty, do you remove them or do you keep them? That's number one. And number two, if you leave the lower part of the anorectum as vagina, does it grow with the child in future?
So that's why we, so the fistula when left as vagina doesn't grow. There is a lot of problem because the parents don't dilate it. It will not grow with child. That's why we didn't proceed with that after 2 patients only, because we seen the results were not satisfactory, and the hypoplastic uterus was left as such. We didn't do anything because it might be that during adolescence under the effect of hormones, if it grows and then it, I don't know. I really don't know how to answer this, but we left it. We didn't remove anything.
Okay, so we can move forward. Dr. Roy, can you present the next paper?
So the next paper is delayed presentation of anorectal malformations in a tertiary care hospital in India. Will be presented by Divya. Divya, are you ready?
Yes, sir. Am I audible, sir?
Yeah.
Good evening, everyone. I'm Dr. Divert from Naramai Hospital, India.
Your volume is low.
Aim of our study was to study delayed complications of KRM management and its effect on surgical and functional complications and outcome. It's a retrospective study over a period of 5 years. And different authors have different criteria to call it as a delayed presentation. And we included all the patients who presented 7 days after birth. Type of ARM, mode of presentation, time of presentation, associated anomalies, management strategy, and post-operative complications were noted. And minimum follow-up period was 6 months. Total 44 patients were included in the study, and most of them were females between the age of 1 month and 12 years. And most common type of PRM we observed was vestibular fistula in about 35% of the patients, that is 15 cases. And in male patients, low ARM is the most common presentation in case of delayed presentation. And associated comorbidities were low birth weight and preterm, and associated anomalies were cardiac, genitourinary, gastrointestinal, and musculoskeletal. And the standard technique we follow in our institute was PSCRP, which was done in about 60% of the patients. And in remaining patients, we have done ASCRP and anaplasty. And the complications we observed during follow-up were constipation in 47% of the patients, and the rest of the complications like incontinence, wound infection, anal stenosis, and rectal mucosal prolapse were observed. And this is the X-ray of the patients who presented late, showing a megarectum, megacolon, and feculomas. And the different types of ARM we observed were vestibular fistula in a patient, in an adult patient, and this patient came for repair before her marriage. And this is the anteriorly placed ectopic anus, and this is the persistent cloaca with single perineal opening, and this is H-type ARM. And this male child presented to us on day 13 of life with metonuria. And the associated complications like syndactyly and hemivertebra were noted. And this is the pressure augmented distal colostogram showing recto-urethral fistula, and this is the type 2 pouch colon with a wide colovesical fistula. And during follow-up, this is the stenos neoanus in an uncompliant patient. And the most common causes we observed in our study for the delayed presentation were home delivery, unawareness, and wrong advice and social stigma, and associated major congenital anomalies. And this delayed presentation will have complications like vomiting, dehydration, subacute or acute intestinal obstruction, and late complications like megarectum, megacolon, and constipation. And the hindering factors for definitive surgery at first presentation include delayed presentation, low birth weight, and major associated anomalies. Children with chronic constipation and megarectum continue to have functional constipation even after definitive surgery. To conclude, delayed presentation is not uncommon and is most common in female patients. Those presenting with chronic constipation and megarectum may require staged repair. And this delayed presentation will have functional and psychosocial complications which can be avoided with early intervention. So to prevent this late presentation, we recommend complete physical examination of every newborn child, institutional delivery, training of traditional birth attendants, and health education. Thank you.
Thank you for nicely listing the cases of delayed presentation. There are two terms. One is a missed presentation and one is delayed presentation. Yesterday we heard about missed presentation, and today what you are presenting is a lot of them have been noticed, but the parents did not seek attention because they were decompressing well. So that's the reason why they came late, like the girl who came before marriage to get the thing done. So a lot of a psychosocial problem. So one is diagnostic issue and the other is social issue. That is what you were presenting. My question to you would be that the group of patients who presented late and you managed them surgically, is there a difference in the outcome with the usual presentation?
So actually, the limitation of our study is there is no control group. And we observed in our patients who presented more incidence of post-operative complications like constipation and incontinence.
So you believe the outcome is poor in patients who essentially present late. So one of the comment is that in a male patient without a low anomaly, but it means that a patient with a rectourinary fistula should be considered delayed if they present beyond 48 hours or after 48 hours. So that's just a comment. Thank you.
Thank you.
Thank you for the presentation. And now we need to move forward with the next paper, number 49. Neovagina structure complicated by high-grade dysplasia in a patient with ulcerative colitis. This is presented by Dr. Veronica Alanis. Go ahead, Veronica.
Please unmute yourself, Veronica.
Yeah.
Okay, can you hear me now?
Yeah, sure.
Yes, we can hear, but we cannot see. Okay, now.
All right, thank you for allowing me to present today. These are my co-authors and we have no disclosures. In patients with cloaca, common channel lengths vary between 1 and 10 centimeters. Vaginal replacement is more likely in those patients with a long channel cloaca. And options for vaginal replacement include rectum, colon, or small bowel. Rectum is typically chosen when there's a poor prognosis for bowel control. When rectum cannot be used, typically a segment of descending colon is chosen because it can be easily mobilized and has good blood supply. There are risks and benefits for using sigmoid as a neovagina. The benefits are that it usually provides a good length and width, it's naturally lubricating, and does not require routine dilation. Some of the risks are dehiscence, excessive mucus production, which can be managed with vaginal irrigations, introital stenosis, which may require an introitoplasty, prolapse, diversion colitis. There are also cases of ulcerative colitis of the neovagina described in the literature, and very rarely dysplasia or malignancy. We're presenting a case of a 17-year-old female with a very complicated medical and surgical history. She had chronic kidney disease that ultimately required 2 renal transplants, a cloaca that was reconstructed with sigmoid neovagina complicated by recurrent vaginal stenosis, and ulcerative colitis that was managed with a total colectomy and end ileostomy at 2 years of age. She had multiple vaginoplasties during adolescence for introital stenosis, and then presented at age 14 with worsening lower abdominal pain, at which time she was diagnosed with a large hematometrocopos. This is a shot of her MRI, and clearly you can see a very distended didelphys uterus with hematosalpinx. The patient was started on menstrual suppression and underwent a CT-guided drain placement, at which time 700 milliliters of blood was evacuated from the uterus. She underwent vaginoplasty with a buccal mucosa graft to create a patent vagina. There was concern for diversion colitis versus ulcerative colitis of the neovagina given her recurrent vaginal stenosis, and she was treated with short-chain fatty acid irrigations for possible diversion colitis. Unfortunately, she developed recurrent vaginal stenosis and was admitted for pelvic inflammatory disease and treated with IV antibiotics. After counseling and an ethics consultation, she underwent an exploratory laparotomy, hysterectomy, neovaginectomy, and a neovagina creation with using ileum. There were no worrisome lesions on her preoperative vaginoscopy, and the neovagina was resected in segments due to a significant adhesive disease. On pathology, we identified polypoid low-grade dysplasia with a focal high-grade lesion in the background of marked chronic colitis. These are 2 pictures from her pathology specimen. On the left, you can see the low-grade dysplasia, and on the right, there's high-grade dysplasia with increased nuclear to cytoplasmic ratio, rounded nuclei, and pleomorphism. The case was reviewed with colorectal and oncologic specialists. Because the neovagina was resected in pieces and dysplasia was identified at the margin, we came up with this surveillance plan. She will be getting serum CEA every 6 months, annual pelvic MRI, and annual pelvic exam for the next 5 years. So ulcerative colitis and diversion colitis can occur in the sigmoid neovagina, and neovaginas affected by colitis are at increased risk of developing premalignant and malignant lesions. Any symptoms of pain, bleeding, or stenosis should be evaluated appropriately. Neovaginectomy is considered for severe and refractory vaginal symptoms like pain, bleeding, and stenosis, and certainly for cases of dysplasia and adenocarcinoma. Long-term surveillance with serum tumor markers imaging should be considered if there's any concern for recurrent or residual dysplasia after neovaginectomy.
Thank you, Veronica, for this amazing case. There is any question for Dr. Alanis?
There is no question in the chat box.
Okay, if there is no any question, Dr. Roy, can you present the next paper, please? You are muted. Dr. Roy?
Yeah, sure. We move to the next paper. And the next paper is on surgical management in patients with intestinal polyposis. It's again a long paper. So it will be presented by Maria. You are on, Maria.
Hello again. Can you see my screen and listen to me?
Yes, you are. You are visible and audible.
Thank you very much. Hello again.
Hello.
Intestinal polyposis in children is an uncommon disease. The main problems are bleeding, causing anemia, diarrhea due to protein loss, and histopathological changes such as dysplasia progressing to colon cancer in 100% of the patient with familiar adenomatous polyposis through their life, and 70% of the patients with juvenile polyposis syndrome. There is controversy on some points, such as when is the best age for surgery, which is the best surgical technique, and whether primary repair or the stage. When the patient presents symptoms, there is no doubt that surgical treatment should be performed at diagnosis. When the patient had no symptom, there is controversy about when the patient should be operated on. There are some published indications established in the literature. Regarding the age, many studies suggest that the surgery should be done between 10 and 20 years, but newer papers publish the greater presence of cancer at the later age of surgery, and they recommend operating on asymptomatic patient at 15 years old. There are many surgical techniques described. Initially, it was recommended to perform a subtoral colectomy and leave a permanent ileostomy, but today, this surgical technique is not adequate for pediatric patients. Subtotal colectomy with ileorectal anastomosis was subsequently described, but this technique is neither recommended for pediatric patients due to the persistence of polyps in the rectum through their life. Thus, proctectomy with ileoanal pull-through appears to be the treatment of choice, although today the debate persists about how to remove the rectum and how to perform the pull-through. Nowadays, rectal resection can be done by mucosectomy or by field thickness proctectomy, both techniques described for Hirschsprung disease. Disadvantages of mucosectomy are bleeding and the presence of polyp in the muscular cuff. Full thickness proctectomy is a more demanding procedure, but today it seems to be the technique of choice in this patient. After the rectal resection, you can perform a straight pull-through or a pouch. The supposed proof for performing a pouch is the lower number of bowel movement after the procedure, described in a meta-analysis. The cons are presence of pouchitis, polyps in the pouch, higher morbidity, mortality and complication because it is a more demanding procedure. But long-term studies comparing pouch and a straight pull-through do not observe differences in the number of bowel movement and continence between both techniques after 2 years after the surgical procedure. Many groups have published good results with primary pull-through, but we believe, as other groups, it should be done in 2 stages, at least in symptomatic patients. A retrospective review of the medical records of 3 patients with intestinal polyposis in our hospital was performed. We analyzed age at diagnosis, symptoms, previous familial history, physical examination, and complementary studies. We also review HF surgery, histopathological reports, and follow-up. Surgery was performed at diagnosis in 2 stages. Firstly, a colectomy with rectum closure and an ileostomy was performed. The second stage was a full thickness proctectomy with a straight ileoanal pull-through. This is a picture of the colectomy with the rectum closed with an intestinal clamp before the Hartmann was done. A temporary ileostomy was performed. Here you can see some pictures of the histopathological study of the patient's colonic polyps. 6 months after the initial colectomy, we performed a transanal full thickness proctectomy, as you can see in the picture, in a similar way when we operate on a patient with Hirschsprung disease. You can see the ileoanal anastomosis after the ileal pull-through. The initial evaluation of the 3 patients was at 3, 6, and 30 years old. All had rectal bleeding as the main symptom, and 2 of them associated rectal prolapse. The oldest patients have a familiar history of polyposis. All had clinical signs and symptoms of anemia, such as pallor and shortness of breath, with low hemoglobin levels, and of the patients required transfusion. They also had low albumin levels. Colonoscopy, an upper endoscopy with biopsies was performed. All the patients had histopathological changes in their polyps, such as dysplasia or atypia. The patient with familiar story had adenomatous polyposis, and the other 2 juvenile polyposis. Between the first and the second surgery, patients improved remarkably. They had significant weight gain, bleeding and anemia symptoms disappeared, and their general condition improved. We waited 6 months between both surgery. Follow-up was 4 months on average after surgery, and the 3 patients have fecal control with 3 or 4 bowel movement per day and no accidents. In conclusion, surgical treatment in symptomatic patient is indicated when the condition is diagnosed. In a symptomatic patient, we suggest to operate of them in the pediatric age. We suggest 2 stages approach with a straight ileoanal pull-through for this patient. Thank you very much.
Thank you, Dr. Maria, for a nice summary of the disease process, their presentation, their diagnosis, and their eventual management. Only thing we have still not seen the long-term follow-up. Now, yeah, my question to you would be, you have said the advantages of making a pouch. What are the disadvantages of not making a pouch? Why would you not make it?
We do not use that technique, but we perform a revision of the literature of the advantages not to do it, is that it's easier in the meaning that we are used to do these techniques in Hirschsprung disease. I mean, a straight pull through, and we are not used, do not use that technique. So for us and for what is published in the literature, it says a straight pull through is a not so complex technique and results are better, less complications, less morbidity, and less mortality. That's what is published in the literature.
Yeah, I do totally agree with you that a straight anal pull through probably gives the same kind of result as a pouch. But I believe many people are still doing a S or a J pouch. And would any senior person would like to comment on the long-term results of making a pouch versus no pouch? Would Dr. Michael would like to make a comment?
We performed J pouch in these cases, but it's you are right. It's a little bit more difficult because it's essential to have no tension on the J pouch. Otherwise, you are getting a stenosis. So you have to mobilize the mesenterium and the mesenteric artery very, very carefully to come easily down with the J pouch to the anus. But otherwise, you have good results. Congratulations, and you are familiar with the technique. It's nothing to say against.
So what is the take-home message for people that give up pouch and just do straight pull through? Give up making pouches and do only straight ileoanal pull through?
What is published in the literature in a big study and the newer one is that in long-term follow-up, more than 2 years, continence and bowel movement are the same. That's what is published.
Yeah, sure. Agree with you. Is Dr. De La Torre, do you have a comment on this?
Yeah, there is another question in the chat, Maria.
Dr. Mansoor, you can unmute and ask.
Why do you do the operation in 2 stages?
Okay, this is a very interesting question. Our patient had very low level of albumin and a very low level of hemoglobin when they were diagnosed. So we do not think that a primary pull-through in this patient, the patient are not in the better condition to have a primary pull-through. That's what we suggest, that in these symptomatic patients, results are better, and it is also published in the literature that when the patient is so symptomatic and with such abnormality in their laboratory exam, it is better to offer a 2 stages approach.
Thank you, Maria, for this comment. Now we need to move forward with the next paper, which is the number 51. And it's going to be presented by Dr. Simi Ratan. The title is Stubbornly Recurrent Rectovaginal Vestibular Fistula Managed Using Scott-Bowley Pull-Through.
एक सेकेंड. Actually, this paper is presented by my resident, and incidentally, then her name was not underlined, but actually she's the presenter of this paper, so she will continue.
Okay, that's fine. Thank you. Go ahead.
Dr. Anju, please start.
Good evening, everyone. I'm Dr. Anju from India. I'm going to present stubbornly recurrent rectovaginal vestibular fistula managed using Scott-Bowley pull-through. Introduction: acquired rectovaginal fistula, mainly a disease of adult female. Pose are especially when the tract is not visualized and the disease is recurrent. Here we present a young girl with rectovaginal fistula in which tract was unclear even on MRI, which posed a management challenge. Report 2 years rectovestibular fistula was operated, opposing anterior sagittal approach without protective colostomy. Patient developed post-operative wound infection and dehiscence, which healed after formation of protective sigmoid colostomy and conservative management. Colostomy closure done 3 months later and after confirming the caliber of anus. But child redeveloped leakage of fecal matter from within the vestibule after the 1 month of surgery and necessitating the stoma again. Here we can see the histologram before the stoma closure was normal, and the panendoscopy also could not delineate any fistula. The washout fluid irrigated from distal stoma as well as that introduced from the anus also did not show any escape from the vestibule. The fistula was taken to be healed and stoma was closed. A month later, again, patient developed fecal leakage from the vestibule and stoma has to be refashioned. MRI pelvis shows only few telltale signs of scarring in perisigmoid region, but no definite tract was outlined. In view of these findings and multiple recurrences, an abdominal approach with endorectal pull-through was recommended to bring healthy vascularized bowel without any dissection of the rectovaginal septum. Here we can see the scarring in the area of perisigmoid region. At surgery, mucosal dissection anteriorly was difficult due to adhesion, but colon above the area of scar could be mobilized and coloanal anastomosis could be compressed. Stoma closure done 3 months later. The post-op period was uneventful and child is doing well after 2 years of surgery and has good fecal continence score. Discussion. Treatment of acquired rectovaginal fistula is a formidable challenge. Severe fibrosis, adhesion around the fistula, and bad operative view make the mobilization and repair of fistula often extremely difficult, causing recurrent fistulization. This is even more so when the preoperatively tract cannot be delineated. In such situations, MRI is the most effective modality with accuracy of around 100%, though it could not delineate the tract in our case. Two main factors to consider planning the type of repair are the location of fistula along the rectovaginal receptor, the integrity of the external instrument. Various methods described in literature are for lower third rectovaginal fistula, it can be treated.
I think we have a little problem with the connection.
If the network seems
so we can.
Audio is also poor.
Yeah. So what we can do is to move to the next presentation, and if we can have a reconnection, we can finish and have the question for this interesting paper. So the next paper, Dr. Roy.
Yeah, sure. Well, the next paper is again an interesting paper. I think this idea is from India, if I am not mistaken. Shar Sutra is the way they say, Ayurvedic sit-on tie for repair of pediatric fistula in ano. We all know fistula in ano is a difficult problem because of its incidence of recurrence may be very high. So let us see if this Indian naturopathic technique has anything new to tell us. Dr. Shilpa. Yes, Dr. Shilpa.
Yeah, good evening, everybody. So at the end of the day, I'll be talking about Shar Sutra. So this may be new for many of you. So Shar Sutra therapy is a minimal invasive technique invented by the Ayurvedics, that is the Indian medicine. It was re-established by the Department of Shalya Chantra, that is the General Surgery Department at Banaras Hindu University. It is being practiced far and wide in our country, and we have a lot of medical tourism as well in this center to get treated for this anomaly. It dates back to 600 BC from the Sushruta Samhita. So what is the Shar Sutra? It's basically a medical thread in which 21 layers of different herbs are put around a thread, which is taken through the fistula. The English medicine has been using it as a set and tie, but the invention has come from this Shar Sutra, that is a medicated thread used to treat the fistula, cut it and make it heal as well. So it cuts through this suture and lays open the tract, and at the same time there is granulation and there is healing without any incision. The pH of this thread is 9.7. It is sterilized by ultraviolet radiations. The indications that where it has been used is fistula in ano, hemorrhoids, pilonidal sinus, and even rectal and anal polyps. We thought we'll use this in children and see whether it works or not, and whether the children are able to tolerate it or not. So 2 cases were managed with this Shar Sutra. The actual procedure is a metal probe which is passed through the fistula, and through the groove the thread is passed. Later the thread is tied and allowed to cut and heal the tract. Both these patients were given the Shar Sutra. One, the insertion was done under general anesthesia, and the other as an outdoor procedure because the 10-year boy was quite cooperative. We changed this thread after a week. Both the wounds healed well, just with 2 insertions of Shar Sutra, and at a follow-up of 3 years, there is no recurrence. It's a simple and parasurgical procedure, cost-effective. The patient remains ambulatory. There is minimal recurrence rate. There is no complication. And even patients with systemic diseases like tuberculosis can also undergo this procedure. To conclude, Shar Sutra works on the principle of excision, scraping, draining, debridement, as well as healing and sclerosing simultaneously without a surgical incision. It can be applied safely in children with good efficacy. Thank you.
Thank you, Dr. Shilpa, for a nice presentation and an indigenous Indian Ayurvedic way of treating a difficult problem. The question which I have in mind is, we know it is being used, it's generally used in adults who tend to have high fistula in ano. What so-called high means above the sphincter. And those are the ones which are difficult to treat because you tend to leave a little part of the fistula high up so that it tend to recur. Whereas in children, most of the pathology is low and they are kind of by definition low fistula in ano because they may be intersphincteric or below the sphincter. So just laying open the tract as we all practice results in good healing. So my question would be, do you differentiate between high and low fistula to apply this Shar Sutra technique? And how difficult it is, the second question would be how difficult it is to find the track to pass the thread through the fistula and bring it all the way around.
So the first question, most of the, like you rightly said, most of the fistulas in children are quite low. But there is a debate on this because we would not like to do a complete opening of the tract for children because it takes time to heal. It may take 2 to 3 months to heal, as we have seen in adults. So most of the surgeons do a fistulectomy. They remove the fistulous tract and suture back both the surfaces. It's not so difficult to find the tract because, as you said, it's quite low. So a malleable probe or a lacrimal probe can be used in the theater to pass it around. And during changing of the thread which is there itself is just cut open and it acts like a railroading. So you can just bring it out from there. What happens in the end is that the medications get absorbed and used, and what remains is only a white cotton thread that is very simple to remove. And it's remarkable to see the healing because there is no pus discharge, no dressings to do, no pain for the patient. So I really found it a very good technique.
And what about the low ones? Would you still do that?
Yes, because it can be done in the outpatient. In fact, the general surgeons have also adopted a technique where you can pass it through a feeding tube as well. So an infant feeding tube can also be used to take the thread around the fistula.
So there are two questions from audience. One is, have you ever tried it in Crohn's disease? Number one. Number two, in children, anal fistula is low and often it heals spontaneously.
I have not tried it in Crohn's disease because this disease is not so common in India. We hardly get to see Crohn's disease in children in India. And what was the second question? It heals on
children,
its own.
it is low and often heals spontaneously.
So the fistulous tract does not heal. If there's a small abscess, it may heal, and it may heal completely. But usually there is a recurrence which may come back after 6 months or 1 year.
Right.
If the constipation remains there.
Thank you. Dr. Pena has a comment. Please welcome Dr. Pena.
I'm sure that there are different populations in different countries, but our experience in, first of all, we differentiate the fistula in anus. If we are talking about a baby male below 1 year of age, we don't do anything. They don't give antibiotics, they drain spontaneously, and then all of them heal spontaneously before 1 year of age. That has been our experience in many, many patients. We follow that routine. If we see a 6 or 7 years old, like the ones that you presented, as at least in United States, the first thing to do is to rule out inflammatory bowel disease. I understand that you don't have that problem, but in the United States, it's very important to rule out that, because if you touch surgically a patient with any procedure with inflammatory bowel disease, the results are going to be catastrophic.
Do you think we should distinguish between congenital fistula in ano and acquired one due to constipation? Professor Pena, do you think the fistula in less than 1 year is congenital in origin?
We don't know if it is congenital or not, but if we see male babies that have a perianal abscess, it drains, and then many surgeons still in the United States, all over the world, do something called fistulotomy. I used to do that many years ago until I found a senior surgeon who said, don't do anything, all of them heal spontaneously, and it's true. They have several episodes of recurrence, like it drains a drop of pus or two, but eventually it closes and heals spontaneously. But of course, we published that in 1990, but surgeons don't like papers that preconize non-surgical treatment. They don't like medical treatment.
Thank you for your comments.
Dr. Shilpa, one interesting comment. Is it patented by Ayush?
It is patented from Ayurveda, but I don't know whether Ayush Ministry has taken it into account because it is available in the chemist shop, nicely packed in the test tubes, and you can get it from the market.
Thank you very much.
I don't think anybody is deriving any patency from that because there is no commercial use of that. It's quite
the final query I have is the size of the thread because it is meant for adults. And that is why I have been having question in my mind how difficult it would be to pass it in a child. Did you face any difficulty?
Not really, because when the child is under general anesthesia, the tract you can easily get it through the artery process.
Thank you. Thank you.
Thank you.
There are no more questions.
Doctor,
so the next.
I have a question for Dr. Shilpa.
Yeah.
What happened with the paper number 52?
Yeah, I was just going to say, so the next presenter will be Dr. Pramod Sharma. So my name was announced,
okay.
So I just came.
Okay.
He will be presenting.
So the next paper, is number 52. The title is Endorectal Pull-Through in non-Hirschsprung disease patients. And it's going to be presented by Dr. Pramod Sharma. Dr. Sharma, are you ready?
I'll just give him a call. Till then, you can move on to the next paper.
Okay, so we move forward. The next paper is the number 54, a rare case of rectal duplication presenting as posterior perineal hernia, and is going to be presented by Dr. Pramod Sharma.
The same author.
Dr. Sharma, are you here?
Yeah, it's the same author as 52.
I think you can move on to the next one, Dr. Nayaz Khan.
Okay, 55. 55, pediatric colorectal carcinoma, an increasingly recognized entity, a series of 7 cases. Dr. Niyaz. Thank you, Dr. Niyaz, finally. Thank you very much. Go ahead.
Thank you, Chairperson, sir. Good evening, all. Greetings from New Delhi. Today, I'll be presenting a series of 7 cases of pediatric colorectal carcinoma. As we all are aware, as we all are aware that colorectal carcinoma is one of the most common malignancies in adults. However, in pediatric age group, it comprises of only less than 1% of all the pediatric neoplasms. Because of its varied clinical presentations and delayed diagnosis as well as aggressive histology, they have got a very poor outcome. So we decided to retrospectively analyze all the patients of colorectal carcinoma who presented to our hospital between period of January 2016 to January 2020. So we found that a total of 7 patients with male preponderance was seen, and the mean age of presentation was 9 years in our series. The interesting point was that the duration between the onset of the symptoms and 8 months. Right-sided colon carcinomas were more common in our series, and histopathology showed that mucinous carcinomas were seen in 4 patients and signet cell in 2 patients. Now, this is one of the patients who presented with multiple perineal abscesses, and on biopsy, it turned out to be a... Sorry. Yeah, on biopsy, it turned out to be... Am I audible now? And on biopsy, it turned out to be adenocarcinoma. So a comprehensive slide of all the seven patients, and I'd like to emphasize that all the patients had very varied symptoms. And in one patient, that is case number 1, a patient presented with abdominal pain, vomiting, and fever for 15 days and was diagnosed as acute appendicitis at some peripheral institute where an open laparotomy was done. The child was later referred to us because on laparotomy there was a huge mass which was seen, and following that we did a biopsy and did an R1 resection and gave adjuvant chemotherapy, the Folfox regimen, and patient was disease free at 1.8 years of follow-up. Another interesting patient was a 9-year-old male who was treated by a physician for abdominal pain and low-grade fever for 8 months and was given anti-tubercular drug, as tuberculosis is very common in our subcontinent. And despite the AKT, the patient did not improve and hence was referred to our institute. And we did a biopsy and it turned out to be a signet cell adenocarcinoma. So going through the literature, there are very few case series and case reports on colorectal carcinoma in pediatric age group as compared to those in the adult. And of late, there are few population-based studies which have been published in the literature. So to conclude, colorectal carcinoma in pediatric cohort is very rare and has got a varied presentation. And there is a need for increasing awareness of this entity among the physician for an early referral to, for better surgical outcome. And there is also a need for pediatric colorectal carcinoma treatment protocol as it is lacking in this age group. Thank you.
Thank you, Dr. Niguez. This is an amazing paper. Big experience with this big problem. Anyone has any questions for Dr. Niguez? You can chat in the box. There is one question. There is
Hello.
a family history of patients. Yeah, go ahead, Roy.
Sure. So there's one question from the audience for Dr. Niaz. Any family history? I believe you have already excluded that.
Yes, there was no family history in any of our patients. They were all sporadic cases.
The other question, Niaz, I would be interested to know that out of 5 or 6 patients, how many of them would you do a complete disease clearance surgery?
Sir,
what I mean is you have completely removed the disease, histopathologically proven in those patients, because that is what will lead you to, survival, long-term survival.
Yes, sir. Sir, definitely, it was only in one patient that we were able to do an R1 resection following chemotherapy, and rest of the patients, they presented very late and they had huge mass which were inoperable. So it was only in one patient that we were able to resect.
Yeah, so that itself proves that they already present in a very advanced stage of the disease, which are not amenable to surgical treatment. So that's very unfortunate in pediatric colorectal cancer. I mean, so with the experience with us, and I was wondering that since now we are talking global and people sitting from all over the world, is it the experience everywhere, or do anyone has a difference in experience and better outcome? Because we all believe that they have an extremely poor outcome, perhaps because of the late detection and advanced disease. Had they been detected earlier, perhaps we could produce better results in terms of their survival. There is a comment. Dr. Paulo published 3 cases of CA in adult population with ARM. Now she suggests that adult ARM patients to have a rectal ultrasound from the age of 25 years old. So association of ARM and long-term anorectal carcinoma.
Dr. Rajadri, yeah.
Sure, please, Professor Gupta.
We had analyzed our cases, I think 3-4 years back and presented during the UPSA Congress. At that time, we were surprised that there were so many cases of rectal carcinoma in pediatric age group were also presented in that meeting from different parts of the world, largest series being 6 cases. We had, I think, 5 cases so far, but the outcome is universally bad. Even in early cases of rectal carcinoma, we detected 2 cases where there was a complete resection of the colon with 5 centimeter margin on either side, no nodes present in the mesentery, and there was a recurrence within 6 months, unfortunately. And so none of them.
So it is inherently a very aggressive disease, as you are saying, with a very poor outcome as we stand today.
That's right. We did consult the adults who have massive experience in this field, but there was no.
So I was just wondering, what is the experience in the other part of the world? Do they see the same kind of?
Universally bad, yes.
Okay, universally.
I think there are only 2 cases survivor in the English literature reported survival with CA rectum in children. Only 2 cases survivors to the best of my knowledge.
Sir, can I add something, if you can permit?
Before you add, Dr. Niaz, I have a question. You did 1 open biopsy, laparotomy and biopsy. Why was that?
Sir, the laparotomy was, the patient presented with acute intestinal obstruction, so we have to operate on that kid. So,
okay.
Go
ahead with your comment.
Yeah. Sir, I just wanted to know, after going through the literature, we found that majority of the management protocol has been extrapolated from the adult literature in pediatric age group. And in adult literature, there's no concept of neoadjuvant chemotherapies. So, but despite that, we tried neoadjuvant chemotherapy, that is FOLFOX regimen, for a few patients, because they all presented late and had huge masses which were unresectable. So, has anybody any experience with neoadjuvant chemotherapy? I haven't got any.
No chemotherapy works for it, dear.
Okay. Thank you, sir.
Thank you.
Okay.
Shall we go on to the next paper?
Hey, Dr. Roy, can you present the next paper, the 56?
Yeah. The next paper is on Hirschsprung and pelvic neuroblastoma, a rare neurocrystopathic association. Will be presented by Dr. Sravanti. Dr. Sravanti, if you are ready, please go ahead.
Yes. Greetings from Chandigarh. I would be discussing the rare neurocrystopathic association between Hirschsprung disease and pelvic neuroblastoma, which we have encountered recently. So as we know, Hirschsprung disease is because of the failure of migration of neural crest cells, and differential growth of the neural crest cells leads to the formation of neuroblastoma. So they represent the extreme ends of a neurocrystopathy, which is nothing but a group of pathologies derived from faulty development in the embryology of neural crest cells. This picture here depicts the complexity of the embryological development of neural crest cells with various lineages. Here, the sacral neural crest cells is involved in the formation of Hirschsprung disease, and the truncal NCC is responsible for the formation of neuroblastoma. Our index case here is a 10-month-old female child who presented with complaints of chronic constipation since birth, abdomen distension, frequent use of laxatives and enema, with delayed passage of meconium in the past history. So all these are in favor of Hirschsprung disease, and along with that, she had recurrent UTI with urinary retention of 2 to 3 episodes. Examination per se was unremarkable. So we proceeded with the contrast enema, which was suggestive of ultra-short segment Hirschsprung disease, and the urological investigations were normal. So according to our departmental protocol, we have done a rectal biopsy with divided sigmoid colostomy, and as expected, there was no obvious transition zone, and the entire large bowel was diffusely dilated till the peritoneal reflection. And the rectal biopsy was supportive of our clinical diagnosis, that is Hirschsprung disease. So after building up the patient's weight and the hemoglobin levels, we have taken the child for modified Duhamel's pull-through. During rectal tunneling, we have encountered a 7 into 4 centimeters well-defined bilobe firm to hard consistency pre-sacral mass. Intraoperatively, we thought it was a teratoma, and excision with coccygectomy was done. The histopathology turned out to be a very well-differentiated neuroblastoma with NMIC negative and MKI index of low MKI index, which fell into the low risk stratification category. So at 1.5-year follow-up, the child is doing well, and there was an ill-defined subcentimetric moderately traced overt lesion of doubtful significance, and the child is under close follow-up and is dated for a PET scan soon. So discuss, there is a complex genetics behind the neural crest cell formation and its embryology, with various genes involved, and mutations or deletions at various levels of these genes will lead to the formation of multiple pathologies. So here, FOX2B gene causes loss of function of RET expression, which leads to the formation of Hirschsprung disease, and a SOX10 gain of function will lead to the formation of neuroblastoma. A hypothesis is that there is a negative feedback between SOX10 and FOX2B genes, which balance the amount of neurons and the glial cells. So a non-polyadenine repeat mutation in the FOX2B gene will cause disruption of this feedback, and thus glial cells are produced more when compared to the neurons. And this occurs very much early in the sympathetic than in the enteric ganglion cells. So the association between Hirschsprung and neuroblastoma may not be by chance, and the exact mechanism is not known. It could be because of this association between FOX2B gene and SOX10 gene, and it needs further research. Thank you.
Thank you, Dr. Shravanti, for a very interesting case. Theoretically sounds very strong, that association between Hirschsprung disease and neuroblastoma, the two neurocrystopathies. I have one question for you on clinical examination, because was this mass not detected on clinical parectal examination or any other imaging studies pre-operatively? That is number one. And number two, yeah, sure, go ahead.
Clinically, it was not palpable, sir. And clinic imaging studies, we did only MCU and contrast enema way before we did a Duhamel pull-through. So we could not pick up the mass in those investigations, sir.
But that such a big mass should have been felt by parectal examination if it's a pre-sacral mass. That's what my take on this. Number two question is the follow-up of such a patient. As you said that there are some PET positive areas and you haven't done anything to them. Should they be treated with some chemotherapy, or what
Sir,
would be
it's
the
a low-risk
protocol to handle?
neuroblastoma, so it is, as of now, it's a low-risk stratification, sir, so it's under close follow-up. So the child may not need active chemotherapy later on, sir. And it is of very doubtful significance here.
Did the parents have a sign of central hyperventilation syndrome? I'm not sure what, it comes from Thomas Webster.
The parents do not have any, they did not give us any history of central hyperventilation. Yes, sir. There was no history suggestive of Ondine curse.
Okay. Right. Any other comments or questions?
Probably I missed it. What was the extent of aganglionosis in this patient?
It was a very short segment, sir. It was at the level of distal 1/3 of the sigmoid.
Because reason I asked, because you know the association of Hirschsprung disease and eminent tumor, the vast majority of patients are have long segment Hirschsprung disease or a total colonic aganglionosis. In fact, we published a paper a few years ago, a meta-analysis. There was about 85 of such tumors in association with Hirschsprung disease. The vast majority were in total colonic aganglionosis.
Yes, sir. The literature was suggestive of long segment or total colonic ganglionosis associated with neuroblastoma, but here our case was not long segments.
Any other questions? If there are no questions,
Okay.
then.
So if there is no more questions, let's move forward to the last paper, number 57. The title is Complications of Sacral Neuromodulation in the Treatment of Incontinence. This is going to be presented by Dr. Rogelio Dominguez from the Hospital Italiano in Buenos Aires, Argentina. Welcome, Rogelio.
Hello, Luis. Hello, everyone. Now I'm from Spain, but this work is in my my practice in Italian hospital in Buenos Aires, Argentina. I present the complication of sacral neuromodulation in the treatment of incontinence. The objective to analyze the results obtained with sacral neuromodulation therapy and these complications.
¿Cómo va el huevito?
Can you hear me?
Yeah, go ahead.
Okay. To analyze the results obtained with sacral neuromodulation therapy and its complication in patients with urinary and fecal incontinence. All patients treated for sacral neuromodulation were included the period 2015 to 2020. Data collect, diagnosis, symptoms before and after sacral neuromodulation with defecation diary, Cleveland Clinic Incontinence Scale, and urinary incontinence with daily evacuation. Previous treatments, behavioral therapy, medication, biofeedback, and posterior tibial stimulation, and response to sacral neuromodulation were considered. The results. 3 out of 10 patients who were treated with sacral neuromodulation present complication that required surgical intervention. 1 patient with anorectal malformation, 1 patient with Hirschsprung disease, and 1 patient with agenesis of corpus callosum. All presented migration of the implant divis. All patients show adequate clinical efficacy with average of 78% from 70 to 90%. In this table, I show the 4 patients before, because 1 patient, anorectal malformation, 16 fecal incontinence scale, and age at onset, 14 years old. The symptoms predominant was pain, and the treatment conservative and analgesic. 60 months, 5 years was this was my first patient. Number 2, Hirschsprung disease, fecal incontinence scale 16, age 11. The symptoms was migration the electrode, and the treatment was recollocation. 58 months. This is my second patient. Number 3, agenesis of corpus callosum. The fecal incontinence scale was 20, the age 24. The symptoms dysfunctional and device and migration. In this case, the treatment was device explant, 18 months follow-up. Number 4, anorectal malformation, fecal incontinence scale 20, age 16. The symptoms, migration device, and the treatment was device explant and placement new device without changing electrode. The follow-up, 20 months. In this photograph, you can see the electrode migration, this recollocation under profound, under deep in the skin. This case is the last patient. Now he is 18 years old. This is the migration device. In this case, the explant device and recollocation new battery after 14 days, a new system, but without changing the electrode. This case, this patient was a dysfunctional device and dysfunctional electrode and migration, and this case explant device and all the system. Discussion. It is estimated that complications appear in approximately 18% of patients, most of these being related to migration of the electrode in the first phase, 11%. There are others such as pain, 15.3%, suspect electrode migration, 8.4%, changes in bowel habit, 3%, and other less frequent, such as problems with device, changes in menstrual cycle, among others. The need for implant revision procedures can be up to 33%. In bibliographic review, this is International Continence Society Best Practice Achievement for Use Sacral Neuromodulation, published in January 2018. This related this complication, and adverse evidence of sacral neuromodulation for fecal incontinence report to the Federal Drug Administration in 2016 is the same. To the conclusions, sacral neuromodulation is the third-line treatment for incontinence. The long-term results in our series have proven to be successful in selected patients. Although the case series are still small in pediatrics, there are elements that show that it's a promising alternative therapy for patients with incontinence. Thank you.
Thank you, Rogelio. There is any comment, questions on this great presentation?
There is a question
one,
from
Rogelio. There is one question, Rogelio. It says, he's from patients with fecal incontinence that they have damage of the anal canal. Do you think they have normal sacral nerves? So, which is indicated for implantation? In other words, in patients with Hirschsprung disease that have damage of the anal canal, do you think do you think they have indication for this device?
Well, it depends of the damage in the anal canal. If you have anal canal some damage, you can prove the sacral neuromodulation therapy, because you have the therapy, you have one phase, you can prove the function for 2 weeks, 14 days. If in this period you can improve the symptom, you can put the battery. But if in this period you can't improve the symptoms, you can take off the electrode and continue with other treatment.
Thank you, Rogelio. There is another question. You explained about 10 patients with this device. 2 had anorexia malformation, 1 had a Hirschsprung disease, and 1 had a genesis of CC. What happened? What is the diagnosis of the other 6 patients?
Well, the majority of cases was anorexia malformation. With Hirschsprung disease, I will have 3 patients, but majority, the 5 patients anorexia malformation and 1 patient plum belly with anorexia malformation.
Thank you very much.
We have another paper, actually. We are not done yet.
Oh, great.
Yeah.
Which one?
There is an interesting paper still left, and shall we go ahead with that?
What number is it?
Sure. Analysis of treatment results for persistent cloaca, and this is going to be presented by Dr. Yulia. Dr. Yulia, are you ready to present?
Yes, I'm here.
Sure, go ahead with your presentation.
Good afternoon to all from snowy Moscow.
Welcome.
So, as all we know, a persistent cloaca is one of the most difficult types of anorectal malformation in children. The choice of the optimal tactics for surgical correction largely determines the final result and the children's further socialization. Therefore, the purpose of our study was to analyze the results of surgical treatment of girls with persistent cloaca. From 2014 to 2019, in the newborn surgery department of the Filatovskaya Children's City Clinical Hospital, 43 girls with a persistent cloaca were operated on. All the patients were divided into two groups according to the length of the common channel. The first group, with a channel length less than 20 millimeters, consisted of 25 girls, and the second group, with a channel length more than 20 millimeters, consisted of 18 girls. The length of the common channel was measured with help of contrast-enhanced CT examination of the pelvis, as well as with help of preoperative cloacoscopy. Differences between groups in comprehensive analysis were statistically insignificant. The choice of the type of operation depended on the length of the common channel. In group 1, all patients underwent posterior sagittal anorexia retrovaginoplasty with the total urogenital mobilization. In the second group, we made plastic surgery with abdominal mobilization. In 12 cases with laparoscopic approach, and in 6 cases, we used abdominal laparotomy approach for girls with the length of the common channel more than 40 millimeters. Also, we made vaginoplastic for all of them. Vagina surgery were performed in girls in both groups. We made an excision of the septum of the doubled vagina for 6 girls on the first group and also for 6 girls of the second group. In other 6 cases of the second group, vaginoplastic surgery were required. In 3 cases, in girls with heterocolpuses and an extended common channel, we performed plastic surgery using the back wall of the hemivagina. 3 more girls underwent bowel plastic surgery of the vagina. The complications after surgery in both groups were homogeneous. In our study, we assisted early complications, late complications, and functional disorders in the long-term postoperative period. In both groups, infection was the main case or cause of early postoperative complication. It in turn led to bowel and vaginal retraction in both groups. The infection was stopped by prolonged administration of antibiotics, and we eliminated the retraction of the vagina and bowel retraction by applying secondary sutures. As for the late postoperative complications, we didn't observe anal stenosis in any case, but vaginal stenosis was found in 2 girls of the second group. Also, in both groups, rectal prolapse was noted in 2 cases. Rectal prolapse was eliminated by surgery. In both cases, we performed the excision of excess mucosa. In vaginal stenosis, we used a posterior wall plasty with a displaced triangular skin flap. All the patients with persistent cloaca after the final stage were included in the bowel management program. Differences in functional outcomes, such as appearance of anal and urinary incontinence in both groups also were statistically insignificant. But the neurogenic bladder dysfunction clearly prevailed in the second group. The evaluation of the result was carried out on the basis of comprehensive examination. We made 4 Malone procedures for patients with anal incontinence and Mitrofanov stoma in 1 case of urinary incontinence. But we can surely boast of excellent cosmetic and functional results too. In conclusion, I'd like to emphasize that the determining factor in the choice of the surgery type in patients with persistent cloaca in the length of the common channel. We believe that the use of posterior sagittal anorexia urethrovaginoplasty is effective when the channel length is less than 20 millimeters. For channel length over 20 millimeters, laparoscopic abdominal mobilization is preferable. If the length of the common channel more than 4 centimeters, we recommended using the laparotomic approach for abdominal mobilization. Malone procedure and Mitrofanovskaya stoma are the main methods of socialization for cloaca patients with poor functional outcome. Thank you for your attention.
Thank you, Dr. Yulia. A nice summarization of a big, complex cloacal anomalies. I have a basic question on your decision of dividing the cases on the basis of 2 centimeter common channel. Traditionally, we speak of 3 centimeter. If I see Professor Alberto Pena's teaching, he says 3 centimeter and above is considered really high and below is considered low. Whereas you have taken it at 2 centimeter break level. What made you to do that?
Okay, I understand the question. We made it because when we need to make a total mobilization without help of laparoscopic approach, we need to separate, to open the back wall of the vagina. When we used laparoscopic approach, we cannot do it. We can very safety be very safety about colon fistula.
Yeah, so the question was that why at 2 centimeter and why not at 2.5 centimeters? Say, for example, would you do a laparotomy for a 2.5 centimeter common channel and not do that for a 2 centimeters? So this is a very subtle difference. And
maybe because in our study, this group of patients from 2 to 4 centimeters, there were girls with the 3rd type of cloaca malformation, which have a high inflow of the colon, but not so big common channel.
Yeah, well, traditionally it is the colon which is not the difficulty. It is the difficulties with the common urethra and vagina, the urogenital sinus, and that what makes the dissection difficult. And that is why people are now combining total urogenital sinus mobilization along with PSARP, where you can even reach higher to bring or do a complete urethrovagino and anorectoplasty without having opened the abdomen. Is Professor Pena still around? Can you comment on his technique of PSARP combined TUM?
I have a question. I enjoy your presentation. When you did laparoscopy, what exactly did you achieve with the laparoscopy? Did you mobilize the rectum laparoscopically, or you repair the entire cloaca laparoscopically? Did you separate the vagina from the urinary tract laparoscopically, or just the rectal? It was a total reconstruction laparoscopic, or just the rectal reconstruction?
Only a rectal decision laparoscopically. The urethra vaginal complex, we mobilized both. We not separated laparoscopically.
Yeah.
Thank you. This brings us towards the end of this session. We would like to thank the chairpersons, Dr. Louis de la Torre and Professor Roy Chaudhary. I will now invite Professor Prem Puri and Professor D.K. Gupta for the closing remarks. And everybody wants to switch on their video and give some feedback as soon as you allow us to do that, whether you want to speak after that or before that. People want to speak out and say a few feedbacks.
Thank you very much for giving us this opportunity. Enjoyed the evening here in India and joining people from all over the world. Thank you, the PCC team, for this great opportunity. Bye-bye.
Thank you, sir.
Thank you, Dr. Prem Puri and Dr. Gupta. Good morning from Denver.
Thank you. Devendra, where are you?
Yeah, okay.
Yeah.
I'm quite okay. And Thank you, Prem. Thank you, board members. Thank you, delegates. Thank you, chairpersons. It's a great pleasure to have held the Pediatric Colorectal Club meeting in India, and we have enjoyed the last 3 days. I'm sure that you are also as much engrossed as we were, along with the organizing team. Let me have the opportunity also to make few slides projected here.
Да, я ему сказала, что только кишку.
So this is for the first time that the meeting was held in India, and we were prepared to host it in September, but now it was to be in December and online, though it was a bit inconvenient to so many people in the far west and far east. So we scheduled the timing to suit them as best as possible. As we have mentioned last time, that we received over 90 abstracts from 20 countries. And then the registration of the delegates, we never anticipated that we will cross our limit of 300 even. The final figure for today is 330 delegates from 40 countries. And we had 72 presentations, of which 58 long, 13 posters, and 2 guest lectures. And interestingly, that almost half of these are from India. So giving a great opportunity to our fellows, trainees, and other pediatric surgeons who usually don't feel comfortable to travel overseas for the cost involved. And you can imagine that out of 330 delegates, 209 are from India. So I think let us confess, and I'm very happy that this meeting has done a great service to a country like India, where there are more than 1,500 pediatric surgeons. This slide shows the...
So we cannot see your slides.
You can't see the slides. How is that? Now share, new share. What is that?
Your screen is being shared, but the slides are not visible.
Yeah. How is that?
Not yet.
It's clear that Devendra, you are lost without Shilpa.
Okay, we had 7 scientific sessions. Still the slide is not visible. So it doesn't matter.
Don't worry, so you can carry.
I don't care. I'm stopping it. So we had 7 sessions and more than 11 hours of discussions, though we had planned it for 10 hours. And the discussions have been on basic sciences, on operative techniques, including advances, genetic studies, and long-term results. And the guest lectures have been very wonderful. So everybody has enjoyed it. So unfortunately, we had planned the hospitality in India like in other congresses, which we couldn't do. We had also some souvenirs designed and planned for all our delegates. The Prem, to disclose that we had a necktie as a souvenir. We had the mug designed specially for this meeting, and we had the sports shirt actually designed for all the delegates. So these are all with me. Those who will be coming to India in future can have that souvenir. These are all reserved with us. And so I think in the end, I would just like to say a few words to my team, Dr. Shilpa, Dr. Ravi, Dr. Neeta, Mahinder, Shivam, and my office staff who are still present. It is almost 10 o'clock, over 10 o'clock here, 10 p.m. in India, and they have been working now and even before that. So big thanks to them to support it. And I hope the delegates, guests, and faculty, they have enjoyed this meeting. We look forward, Prem, to see you in Dublin next year. Thank you very much.
Devendra, thank you very much. This has been a highly successful 27th Pediatric Colorectal Club meeting. We were certainly worried in the beginning, but in the end, it's been more than we expected. And also to tell you, over the years, the Delhi meeting or this virtual meeting, we had the largest number of delegates attending the meeting, as well as the largest number of countries representing it. And on behalf of all the delegates, I would like to thank you and your team for making this a very successful meeting. And hopefully next year we'll be able, next year the meeting, the colorectal meeting is in Dublin, Ireland. And we're hoping by that time, all of you will be vaccinated and we can have a face-to-face meeting in Dublin. At the moment, it is scheduled to be in June, but we are hoping, hopefully, it will be postponed to September. It all depends when the UPSA meeting will happen, because our meeting in Dublin will be just 2 days before the UPSA meeting. UPSA meeting this year is in Athens. So once again, thank you, Devendra. Thank you, your team. And most important, thank you all the delegates who have participated despite of the time factor. Sometimes it was early morning in Denver and late night in Tokyo, and people have, have not bothered about the time and have given all these 2 days. And then also on Friday, we had the board meeting, which was highly successful. Once again, have a lovely time and hope to see you face to face soon. And I'm sure this COVID-19 pandemic will be soon over. All the best to you and your families. Thank you very much. Thank you.
Congratulations, sir.
Thank you. Thank you, sir.
Professor Gupta.
Thank you, everybody.
Fantastic meeting.
Go back home safe. Happy journey.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you. All the best, sir. All the best.
Thank you.
Thank you, Shipa.
It was really
Thank you.
amazing.
Great work.
Thank you, Michael.
Great work.
Thank you.
Thank you, sir, for this wonderful meeting. Thank you, sir.
Welcome.
Thank you. Thank you from Italy. Thank you.
Great, sir.
Thank you from Russia, from Moscow. Thank you so much.
The only one from the Gulf.
You're always there.
No,
Thank
there
you.
are three. Amin, Gohari, Ifti, yourself.
Yes.
Right.
Nice to see you all, everybody.
It has been a pleasure to see you all. Faiza, you are always there.
Thank you. Thank you from Italy also.
Thank you.
Very nice paper. Very nice.
Hopefully we meet again in Dublin next year.
Yeah.
Prem.
Thank you from Iran.
Prem, I just tell you, Prem loves to drink whiskey.
Yeah.
Tell
That's
him more.
what we missed at this meeting. No drinks.
Okay.
Thank you from Mexico. Happy Christmas and Happy New Year for everyone.
Long way, Mexico. This COVID time has saved you from that 48 hours of travel. From India to Mexico.
It's been in my heart, but Mexico in place.
Devendra, soon we'll have whiskey together.
It's always welcome, Prem. We look forward for that. I have some beautiful collection for you. If you want to enjoy a single malt, always available.
Or an old monk rum.
Oh, yeah. Michael, you are overdue to visit India.
Yeah, I know.
Thank you very much, everybody from Bangladesh. Thank you very much, D.K. Gupta, sir.
Thank you,
Thanks to you.
Mitul. Say my hello to all your friends in Bangladesh.
Yes, sir. Thanks to Madam. Hello to Madam and everybody. Good night, sir. Good night.
Prem, I am happy that so many Indian fellows, trainees, and our colleagues could join this meeting. And that was our purpose, that they should benefit.
But it was very good because so many people joined it. This was we wanted, and we were been very happy.
The very purpose of PCC has been served, that it should go to the people who need it most.
No, it has been a very successful. Wonderful.
Thanks so much. You have been the pillar for all the plans, scientific programs, advices. Never hesitated to guide advice whenever it was most needed. So
credit goes to you also.
Credit goes.
Credit goes to you always. That you and Professor Prem Puri are really pillar of this pediatric surgery for India.
Our friendship is the main main reason for the success of all these meetings. Let me put it this way, yes.
That
complete transparency.
Sir.
Publicly, I acknowledge that this is what it is the strength, 1 and 1 making it 11.
Yeah, that's why that our success of that meeting is always there, that because of Professor Prem Puri Association, he's been associated with you for the last so many years.
And we feel happy that at least we are able to keep the Indian flag flying at the international level.
Yes, that's always, because this was the international meet and you have made it success during this pandemic of this COVID.
That is
Thank
the
you so
real
much.
problem.
Congratulations to all of you and your team, sir. Once again.
Thank you, Grover Saab. Thank you so much.
All the best. Take care. Take care of yourself. Bye.
You have always been the strength for all these meetings, organization. You are a multi-purpose hard taskmaster.
Even though I love to have you to attend your meetings. You see, not only meetings, your chat does everything. But this was a real subject, even though I love to attend this.
Okay.
Thank
you. Thank you, Professor Puri. Thank you. Bye-bye.
Thank you, everybody.
Thanks a lot, Dr. Gupta. Thanks a lot. See you.
Thank you, Ushaji.
It was nice to see so many Indians attend.
Yeah.
When we had the
Thank you for the excellent meeting, sir. Thank you so much.
Thank you.
When we had the research meeting, that's what we missed there. Not many Indians came, but we're delighted to see so many Indians participating in it.
I was just discussing with Shilpa yesterday that now we have the infrastructure. I have become little familiar. That is the advantage holding this meeting online. At least I have started using Zoom to some extent. This is my first involvement deeply with the Zoom arrangement. That we can have such meetings once in a month for a group, those who want to present interesting cases and they want to discuss in a very informal way. So I think that will be very educational at our national level.
Once a month, once every 3 months.
Maybe, yeah.
Every 3 months, sir, not month. 3 months will be more benefit.
Yeah, okay, okay. So Shilpa, you take the mantle of responsibility once in 3 months, and we have a couple of overseas experts to participate online at their convenience. Prem, is that a good idea?
I think very good idea, but once every 3 months is
But it should be a plan meeting. It should be a plan meeting. It should be a plan announced meeting so that everybody could have planned this.
Those who want to join, they can join.
Plan.
Once again, thank you very much. Shilpa, thank you very much if you're still there.
Most welcome. Thank you so much.
Shilpa is always with us. Shilpa, congratulations to you and your
Thank
team.
you. I think this is the longest time we've all sat together continuously.
Absolutely, absolutely.
No tea time, nothing. Everybody's glued to their screens.
Good. But it's a good, nicely presented, nicely squeezed, that international, that thing.
Well, I was served by my staff here, tea, coffee, soups in between, so no problem. So
You didn't have to get up for that.
no,
We
they
can
were
have a
taking
cup of coffee or a cup of tea with you. Okay, sir.
right, Grover Saab. Okay, thank you.
Bye-bye. Thank you, sir.
Okay, Prem, say my regards to Veena.
And then, Devendra, just to tell you, I don't know, not many people are there. I hope nobody else is listening. But my sister was admitted today to the hospital with COVID.
Oh my God.
Mm.
So
What does that
it is the same, you know, the family. Once your brother-in-law was admitted and
No,
now
he was discharged and okay. But my sister is now admitted, and she's quite